Well, good morning and welcome. My name is Joe Cressy, and I have the privilege of chairing the Board of Health. Our board secretary has confirmed that we have quorum, so I will call meeting 31 of the Board of Health to order. Welcome, everyone, and especially welcome to fellow board members who I see on the screen. I would like to especially welcome Councillor John Fillion. Councillor Fillion was recently appointed by City Council to the Board of Health. He has replaced Councillor Brad Bradford, and so on behalf of all of us, I would express our deepest gratitude and thanks to Councillor Bradford for his time on the board, and to Councillor Fillion. For those who don't know, Councillor Fillion is the Board of Health. In fact, he was chair of the Board of Health for 13 years in previous terms, and so it is our immense benefit, John, and I'll say that sincerely as a friend, to have your wisdom and guidance here as we not only look to end this pandemic, but build a new and better normal. And so it is our benefit to have your guidance and wisdom with us again. So board members, welcome to John. He also just got a haircut, which is important too.
Thank you. Looking forward to it.
Thank you, sir. Today's meeting is being held with members of council, city staff, and board directors participating by video conference. The public can continue to participate electronically and can watch the meeting streaming live on YouTube at youtube.com/Toronto City Council Live. I will ask, of course, everyone for their patience with any delays and technical issues. We do have a number of registered public speakers, all of whom have been connected to the meeting by audio. I will now turn it over to Director Peter Wong to provide the land acknowledgement and statement to begin today's meeting. Director Wong, over to you.
Thank you, Chair Cressy. The land acknowledgement is an expression of gratitude and respect for the land, and one that has been practiced long before European settlers arrived on Turtle Island. By making this land acknowledgement, we take part in reconciliation. We honor the land and we recognize the presence of Indigenous peoples that dates back over 10,000 years. So as we meet today on this virtual platform, the good mind tells us that we would like to recognize that our work and the work of our many partners take place on traditional Indigenous territory across what is now called Toronto. So today, as settlers in Toronto, we would like to acknowledge that the land we are meeting on is a traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis peoples. We also acknowledge that Toronto is covered by Treaty 13 and the Mississaugas of the Credit. Miigwech, Chair Cressy.
Thank you, and Miigwech. Thank you, Peter. Are there any declarations of interest under the Municipal Conflict of Interest Act? If you have an interest, please raise your hand and unmute your mic to indicate so. Caucus now. Seeing none. Next, we do need a motion to confirm the minutes from our last board meeting on September the 27th, 2021. I see moved by Trustee Donaldson and seconded by Director Bowery. All those in favor? Opposed, if any, that carries. Let's proceed with the agenda review. We have 7 items on the agenda and a number of presentations associated with a number of them. So we'll begin item HL 31.1, response to COVID. We have both registered speakers as well as presentations on that item, so it will be held down. Item HL 31.2, Black Scientist Task Force on Vaccine Equity update. We do have presentations on that item, so it will be held down. COVID-19 recovery update. We have the city manager, Chris Murray, who has joined us here today for that presentation, so that will be held down. Item HL 31.4, Toronto Public Health 2022 operating budget submission. Would anybody like to hold that down? Okay, I can move an amendment here if we want to dispense with that now. I have that the Board of Health adopt the recommendations in the letter from the Board of Health Budget Committee. Board of Health Budget Committee, and if clerks, if that can be put on the screen, This is at our December meeting, a request for the MOH to provide details on 6 budget proposals related to our overdose work, as well as recommendations related to them. And so with that letter from those recommendations from the Budget Committee, and thank you deeply to the members of the Budget Committee who have been in a series of meetings preparing for this, and to Althea Hutchinson and the entire team who have done incredible work in another challenging year around budgeting. With that, I can move this forward. Okay, all those in favor? Opposed, if any, that carries. As we can carry on with the agenda review, item HL 31.5, Toronto Public Health.
Oh, Mr. Chair,
Yes,
it's sorry to interrupt
as
you. This
amended?
is- Yes,
Okay.
it's
My
just because it's the
apologies.
budget.
So on item HL 31.4, we endorsed the amendment from the Budget Committee, and now we need to endorse the item as amended. Thank you very much, Julie. All those in favor? Opposed, if any? Carried. This place would not work without the Clerk's Department. Thank you, Julie. Item HL 31.5, Toronto Public Health 2022 to 2031 Capital Budget Plan Submission. Would anybody like to hold that item down? Okay, seeing none, would anybody be willing to move the recommendations contained there? Moved by Councillor Ainsley, thank you. All those in favor? Opposed, if any. Item HL 31.6, regarding the lease for Toronto Public Health Dental Clinic located at 235 Danforth Avenue. Would anybody like to hold that item down? Okay, seeing none, would anybody like to move the recommendations from staff? Moved by Director Bowery. All those in favor? Opposed, if any, that carries. And then the final item on the agenda for the run-through is item HL 31.7, Early Identification and Intervention Services for Preschool Children in Toronto, Next Steps. There is a confidential report that has been provided. If there is an interest to go on camera on this item, we should make note of that now. Otherwise, I'd look to see if anybody is able to move the amendment, or not the amendment, sorry, the staff recommendation in front of us. All right, I will move that. So the staff recommendation, all those in favor? Opposed, if any, that carries. Okay, so that brings us back. So we have 3 items then on our agenda. 31.1, the COVID update, 31.2, the Black Scientist Task Force update, and item 31.3, the COVID recovery update. I will note, just for everybody's planning purposes, we have presentations on each of these. So we will begin with item HL 31.1, the COVID update. We will have a presentation from Dr. Davila, as well as our Associate Medical Officer of Health, Dr. Dubé. And then we will have a presentation from Anania Grant, the Director of Community Resources at Social Development and Finance, as well as Dr. Nakashi Lampe, our Deputy Medical Officer of Health. And so we then also have speakers on this item. So we will begin with the staff presentation. We will then move to the public speakers before returning into committee for questions of staff. With that, for those of you who graduated from York, you might have seen a front page cover on the People's Doctor, as they refer to her. It is my pleasure to turn the floor over to the People's Doctor. We will formally change the name of your title soon, Eileen. So Dr. Davila, over to you. The presentation on the floor is yours and your colleagues.
Thank you, Mr. Chair, and good morning, everyone. And I will thank my colleague Dylan for generously driving the slides for us this morning. So we're going to take you through, as the chair has just indicated, the first part of a staff presentation update on our response to COVID-19. And this is our update, of course, since the last time we met at the end of September. Going to the next slide, let's start off with where we are now. The next slide depicts our monitoring dashboard, the most recent update of which was provided last week. And as you'll see across the board, we are generally seeing improvements in pretty much every metric. Just to call your attention to a few, that 7-day moving average of new cases is depicted at the top left corner of the slide. It's now sitting at 69. And the weekly incidence rate of new COVID-19 cases is now sitting at 17 per 100,000. To give you a sense and a bit of a reminder as to where we were a month ago, 7-day moving average when we last met as the Board of Health was 143, and again now 69. That weekly incidence rate at the end of September was sitting at 35 when you last gathered around this WebEx, as it were, for this meeting. Now it's 17. And we're also seeing improvements in new hospitalizations, now sitting at 2.7. Last time when you met, it was 5.3%. Positivity is now sitting at 1.2. And the last time you met, it was at 2.7. So general improvement overall in respect of the metrics that we're following around COVID-19. And again, it speaks to all the work that has been done, and we're going to get into more of that over the course of the presentation. To the next slide, though, at this time of year, we are, decidedly in the fall, and this is indeed, as it is every year, a cold and flu season. So it's not just about COVID-19, and this is the time of year that we have to think about other respiratory viruses, the most prominent of which, and certainly the most spoken of, would be influenza season. So this is something we are absolutely getting ready for. With the annual universal influenza immunization campaign that we deliver locally, and this is a provincial program that's delivered every year. Of course, there are other viruses that are already circulating over and above COVID-19, and we expect that this will continue through cold and flu season. I think the important point to make here for the board and for the public in general is that there is a lot of interest in understanding, what might we anticipate in respect of this year's flu season. Last year, we did not see much by way of influenza. So as a result, there's reason to believe that immunity within the population might not be as high as we would normally expect, because we weren't exposed to influenza in quite the same way as we normally are in a given cold and flu season. So certainly some reason for concern that there may be a more significant flu season this year. And you will have heard from our provincial counterparts that they are planning for the largest influenza immunization campaign in the history of this province. And flu vaccine should be available to the general public starting next month. And we are obviously not just actively planning, but doing all the preparatory work and the support that's required for healthcare providers to deliver this vaccine in our community. Clearly, some of the public health measures that we have been promulgating over the course of the last year and a half or so, things that actually work in respect of COVID-19, including masking and physical distancing, obviously also help with respect to the control of other respiratory viruses that may be impacting our community. So, of course, we will continue to support people in practicing those measures. The next section of our presentation to date has to do with vaccination. We'll go to the next slide. And this is a slide you're familiar with and you will have seen before. Lots of activity happening in vaccination, clearly not at the same rate as perhaps as earlier in the campaign, but we continue to see slow and steady progress in respect of the proportion of those who are vaccinated in our community, whether we're looking at those who are eligible for vaccine and how that reflects as well in the overall share of Toronto residents who are now receiving the protective benefit of vaccine and protecting those around them as a result. We continue to see more and more vaccines administered to Toronto residents. In fact, since September the 5th, over 240,000 doses have been administered to Toronto residents. So we are continuing to see more and more progress in this regard. This is an incredibly important tool that we have available to us in terms of combating COVID-19. It's particularly important in light of the very transmissible Delta variant, and certainly the experiences that we're seeing from other parts of Canada and throughout the world speak specifically to the benefits of vaccine. I'm actually now going to turn the slides over very briefly to my colleague, Dr. Vanita Dubé. But I do want to, one, emphasize before we get into some of the evidence and some of the other specifics around vaccine, first and foremost, The success that we've had, the number of people we have been able, in partnership with other healthcare providers, to vaccinate in our city is truly remarkable and is a major achievement. I think it is a major contributor as to why we are where we're at now at this point in the COVID-19 pandemic in our city. You will have heard, I'm sure, through media reports that in general, we are doing quite well, and that actually manifest in that which we're seeing in our monitoring dashboard. So I just have to emphasize for the board, this is incredible progress that has been made in our city in respect of the vaccination campaign, and as a result, on COVID-19 and controlling COVID-19 in our city. But I am going to turn it over to my colleague, one of our Associate Medical Officers of Health, Dr. Vinita Dubé, to present a little bit more on the next slide. I do want to call the attention of the board members to the fact that, we are very fortunate to have really incredible staff at Toronto Public Health, and amongst them are Associate Medical Officers of Health. Really incredible skills and true professionalism I've witnessed over and over again. And this is certainly true of my colleague, Dr. Dubé. She also, not only is she a great physician and a great contributor to our team at Toronto Public Health, I should bring to your attention that she is a member of the National Advisory Committee on Immunization and is widely regarded here in this province, and I would dare say beyond, as one of the key experts that we have, probably one of our greatest tools, if you will, in respect of combating vaccine preventable diseases, and in particular at this time, COVID-19. So with that, I will turn it over to Dr. Vinita Dubé to present on the next slide.
Thank you very much, Dr. Davila, and thank you for that very generous introduction. I'm actually very pleased to talk about the COVID-19 vaccines because I absolutely agree with you that it's the vaccinations that have really played such a critical role in where we are at right now during this fourth wave. And really to emphasize that the vaccinations, every vaccine that we can get in an adult or a parent or a caregiver is actually helping to protect the children who can't be vaccinated as of yet. So moving on into some of the points on this slide, I think it's really important to emphasize that we have a really strong vaccine approval process. Canada actually has one of the safest and best vaccine safety programs in the world. So before a vaccine is even approved, you can see right now Health Canada has received the package for childhood vaccinations, and they're taking their time to review all of the data. If there is data that's missing, they will go back to the manufacturer. They will only approve and license the vaccine when it is considered safe, when the vaccine is considered effective, and when the manufacturer has met all quality standards to ensure that they will be able to produce a good vaccine. So that approval process is in play right now with the childhood vaccines, for example. And even after a vaccine is approved, we in Canada have a vaccine safety program to which Toronto Public Health is a part, where when people have adverse events following immunization, they can either report them directly to Toronto Public Health or through their doctor, and these are all assessed to ensure that we continue to monitor the safety of these vaccines. Now we have vaccines for our youth now, youth aged 12 to 17. There actually has been great uptake of the vaccine in these children. Now we know that children in general can have milder symptoms of COVID. Some can be asymptomatic, including 20 to 30% of children. However, some children can get very sick, even otherwise healthy children. They can also spread COVID to others. And this is one of the reasons why we continue to encourage youth who are 12 to 17 years of age that they get vaccinated. It will help them to protect themselves, but also to prevent the transmission to others, including younger siblings, family members, and also to grandparents who may not have as strong an immune system. Now, I've mentioned that the vaccine continues to be recommended for 12 to 17 years of age, and it is the Pfizer vaccine that we are giving right now to this age group. Now, people often wonder, what if I have a health condition? Should I still get the COVID-19 vaccine? I actually know, as you know, from my work in the emergency department, that some people with chronic health conditions actually are waiting out on the vaccine because they feel they have so many other health conditions. But in fact, when you have a health condition, that's all the more reason for you to get the COVID-19 vaccine. And the vaccine has certainly been proven safe in anyone who has health conditions, including allergies. And actually, just last week on Friday, the National Advisory Committee on Immunization released new recommendations based on an assessment of the data that showed that even someone who's had a severe allergic reaction, including anaphylaxis to the vaccine, like Pfizer or Moderna, an mRNA vaccine, they can still get a second dose of that vaccine if assessed by an allergist and given through controlled settings. But anyone who has heart conditions, has cancer, has high blood pressure, cholesterol, asthma, ADHD, for example, we get these questions about children as well. They can safely be vaccinated with the COVID-19 vaccine, and it's actually recommended for them because they can often be at higher risk for getting a severe illness. Now, you've heard about myocarditis and pericarditis following COVID-19 vaccines. This continues to be a rare adverse event following immunization that has been identified following the messenger RNA vaccines, Pfizer and Moderna. But it's important to know that if you get COVID, you can also get myocarditis and pericarditis. And I can actually share some of my clinical experiences where in the spring, I had a 42-year-old male who was diagnosed with pericarditis, was not vaccinated. And at that time, vaccines were just being rolled out, was not eligible, was not vaccinated, had pericarditis. Roll it through, and he had when you get pericarditis as a young adult, you can get it very often from viral infections, and often the treatment can take time to heal the heart and certainly requires close follow-up. Moving along a few months later, I saw a young adult in his 20s following the Moderna vaccine. Within the first week, had a little bit of chest pain, had pericarditis. The difference between the two clinically was very evident. Following vaccination, the myocarditis or pericarditis is milder. It's often treated with rest, over-the-counter medications, and is not associated with ongoing concerns clinically. Now, this continues to be followed very closely, but the benefits of being vaccinated, even if you get a rare case of myocarditis or pericarditis, still is more beneficial compared to getting COVID and the risks of getting, for example, a myocarditis from that. And again, this is the reason why we continue to give the Pfizer vaccine for those who are 12 to 24 years of age in Canada, in Ontario, because the Pfizer vaccine has a lower risk, even lower risk of this rare complication. Okay, next slide, please. So moving along to some of the vaccine planning, as you know, there is a lot that is going on for the 5 to 11-year-olds. Toronto Public Health is collaborating with our health sector partners to plan for clinics. And the health sector partners are also, we're also connecting with school boards, community representatives, and the Ministry of Health to have a really diverse plan to be able to vaccinate this age group. The vaccine will only be available, though, upon Health Canada approval. And then the Ontario Ministry of Health has to be able to receive the vaccine and be able to provide it to be able to give to the children. The vaccination strategy will be informed based on a needs-based approach, and you can see that it will be different from the adult vaccination strategy. For example, schools as a location where vaccines are provided may be more preferable, for example. And we're currently doing some work to get some more information from parents to find out what are some of their preferred places to receive the vaccine. There also continues to be vaccine planning for the third dose administration. Right now, currently, if you have a weakened immune system, you're immunocompromised, there with a long list of conditions, any of them, you are eligible for a third dose. If you live in a long-term care home or a congregate setting for seniors, you are eligible for a third dose. But we anticipate that there will be recommendations forthcoming from the National Advisory Committee on Immunization, for which the Ministry of Health will likely adopt regarding third dose vaccines. And so we are planning for that when they become announced and available. And then finally, just to note that the last mile vaccination continues. This is actually probably still one of our best and most influential vaccination strategy, because it continues to get those who are unvaccinated their first dose and their second dose, and ensuring that we have, again, that broader coverage among those who are unvaccinated continues to be actually one of our best strategies to combat COVID. And with that, I will turn it back to you, Dr. Davila.
Thank you, Dr. Dubé. And we'll go to the next slide. And this section of the presentation goes into some policy updates since the last time the board met. So next slide. High-level summary depicted here around some of the changes that have occurred in the last month or so since we were last gathered here at a Board of Health meeting. I won't go into details in them, but suffice it to say that, you know, as has been the case over the last year and a half, almost 2 years now, there are constant changes happening in concert with that which is being seen on the ground around the COVID-19 pandemic, the epidemiology, and constant policy updates in and around managing COVID and securing at this point the progress that we've made to date. Some of those changes clearly happen at the provincial level, and some happen at the municipal level. You'll see here that, as Dr. Dubé mentioned, there were some changes made at the provincial level around which vaccine was recommended for younger recipients of vaccine. We heard provincial updates in respect of testing, as of course testing is within the provincial purview. As Dr. Dubé pointed out, we've heard provincial guidance on third doses. We've seen proof of vaccination policies and technologies to support that. And most recently, just at the end of last week, we've seen a provincial announcement in respect of what next steps look like in the pandemic. From a municipal perspective, it's important to note that we did, since the last time the board met, issued a letter of instruction around proof of vaccination requirement to take effect as of November 1st for participants in indoor sports and recreational activities for all those aged 12 and up. And I think it's of relevance to the board to know that similar instructions have been issued by the majority of local public health colleagues throughout the province. On the next slide, though, this is the overall time frame or timeline that was just put out by the province this past Friday in their plan to safely reopen Ontario and manage COVID-19 for the long term. That's the plan that they have articulated just at the end of last week. And these are the relevant dates that they have put forward at the provincial government level in respect of what they see as the path forward. I won't go through this in detail. This is certainly something that received a lot of media attention at the end of last week, and I suspect we'll continue to hear from the province around their ongoing monitoring of the situation and how this manifests, you know, in terms of their changes and openings and the plans to withdraw restrictions over time. My hope is that they continue to really monitor very carefully that which is happening and to base the actions taken not so much on a prediction of what might happen in the future, you know, certainly when it's far, far away, but to think about what makes the most sense given all the lessons that we've learned thus far over the course of this pandemic. We have certainly seen that when this virus is given the opportunity to spread, particularly when you're dealing with a very transmissible variant of this virus, it will take advantage of that opportunity. So I would urge continued caution, while of course being optimistic about the progress we've made to date, but continuing vigilance around doing what needs to be done to maintain that progress. Turning to the next slide, just a little bit more in respect of testing, as I know this has been a subject of a great deal of interest, not only here in Toronto, but throughout the entire province, particularly as we wait for vaccine to be made available for those who are younger in our population. So lots of interest, obviously, in respect of testing, and particularly for school-age children. I would say this, we are incredibly fortunate here in Toronto that we do have good access to testing. In our particular case, we have a number of COVID assessment centers that are available for people to actually get access to testing. And for schools in particular, we're fortunate, thanks to the work of certainly our team at Toronto Public Health, but in significant partnership. There is a very heavy lifting component here that was done by our healthcare partners, notably the Hospital for Sick Children, Michael Garron Hospital, and Women's College Hospital. So we're very fortunate as a result of the work with these partners that we have take-home PCR testing in our schools. And we've worked very hard with our partners, including our school board partners, to make these take-home PCR tests available. And as you may have seen, we've very pleased to announce that we now have available physically at each school by the end of this week in our publicly funded schools. There will actually be physically available on-site take-home PCR test kits at all publicly funded schools in this city. So there are other testing modalities available, and thankfully, as I have relied on her earlier in this presentation, we have Dr. Vanita Dubé, who's a little closer to this work with our schools team, and is going to just speak a little bit more about these tests and what we have made available and how we're using tests and our available resources to best effect in terms of protecting kids and staff within our schools.
Okay, thank you, Dr. Davila. This is an infographic on a slide here, actually, that we have available for principals and parents to actually help them to understand what tests are available, because it certainly is confusing, and not all tests are equal. And so the first box there is what Dr. Davila talked about, the take-home PCR test kit. And that certainly is one of our preferred testing modalities for children. It is recommended that students in schools use this if they have even one symptom of COVID-19, or if they are in a cohort that has been dismissed, they have been considered exposed to COVID-19. We're recommending in that setting that all students and staff get 2 tests, one right away and one 7 days later, even if they are fully vaccinated. And so they can use the take-home PCR test kits for exactly that purpose. Now, the test kits can often be returned either to a school or to a specific location to drop off. And it makes it much easier for parents and students alike to get testing done without having to worry about making an appointment or going to an assessment center. These are also self-collection tests, and so it's either collecting a saliva sample or just a swab in the mouth or nose, which is often quite a lot easier for students as well. The next type of test is the testing that's done at an assessment center. Assessment centers continue to do PCR testing, again, that gold standard preferred test. The test that's done there, sometimes you don't have a choice whether it's a deep nasal swab or a saliva test, but it is a good place to get a test if you have symptoms or if you are, again, a close contact of someone from COVID. You have to meet the provincial criteria in order to get a test at an assessment center. The final modality that we have are the rapid antigen tests. that have only recently been made available to public health in schools since the beginning of October. Now, the rapid antigen test is not recommended if you have symptoms or if you are a close contact. It is what we call a screening test. It's not a diagnostic test. So if you get a positive on a rapid antigen test, it's a screen positive, we say, and you're required to then get a confirmatory PCR test through one of the other means that I talked about. The rapid antigen tests have specific test characteristics, such that if you are living in a community where there's not a lot of COVID that's spreading, for example, you can end up with false positives or false negatives, depending upon the community characteristics. The province has announced specific type of uses for the rapid antigen test. We continue to work with the province to determine the best way to use these tests in Toronto. It's a bit of a different situation here because we have access to take-home PCR test kits, which is not available all across the province. And we have recently used the rapid antigen test kit for schools that we had a whole school dismissal. All of the students and staff returned back to the school, and the test kits were provided to the students and staff voluntarily to use over a 2-week period. So you do a test twice a week, say Tuesday and Friday. 5 tests were available per kit. And that was considered an additional layer of protection in that setting of a whole school dismissal. And so we continue to explore best uses of this type of test again in Toronto. Back to you, Dr. Davila.
Thank you, Dr. Dubé. And on to the next slide. We're nearing the end of our presentation. Just wanted to make sure that the board members were aware that clearly, this has been a very significant response to COVID-19, and it has required the redirection of, the majority of our resources available to us as a local public health unit in order to mount that effective response. So we actually only have a small proportion of our resources and our staff able to continue to carry out other essential functions outside of that which is required for the COVID-19 response. And clearly this has impact on work to address a variety of other issues that clearly have impact on the health of the residents of this city. This slide depicts some of the major categories of areas of work that we would normally be undertaking, that unfortunately we are not able to undertake at this point in time, given the need to redirect resources towards the COVID-19 response. And I just wanted to make sure that the board was aware that this is, in fact, one of the realities of our circumstances, and it's certainly not unique to us. In conversation with local public health providers and professionals all over the world, this is something that everybody is experiencing as a result of the COVID-19 pandemic and the response that's required. So that takes me to the end of the formal part of our presentation. I know that my colleagues Anamia Grant and Dr. Nakashi Lamptey have an update for you. I did just want to make a few closing comments to the board, though, in respect of this part of the presentation. First and foremost, I think that the progress we've seen to date, the declines in the case numbers and in the metrics overall that I described at the outset of this presentation really do demonstrate the importance of vaccination and public health measures overall. And in fact, they reflect the many efforts of Toronto residents who've really done their part to prevent the spread of COVID-19. And so, of course, to the people of Toronto, I offer my thanks. I would encourage, of course, that we need to maintain this momentum. And as a result, we will need to continue these efforts. Getting vaccinated, continuing public health measures like masking and physical distancing are key to maintaining the progress that we've made to date. As I do every opportunity I have, I do want to thank colleagues throughout the City of Toronto. And as always, special thanks to the Toronto Public Health team who've worked tirelessly to respond to this pandemic. you'll hear me say this. You've heard me say it before. You'll hear me say it again. Counting through the days that we've been, active in this response. As of today, it's 640 days since that identification of the first case of COVID-19 in Toronto. And I would just remind all of us that more than ever, we need to be mindful to preserve staff capacity, to recognize the very real toll the response has taken on our team. As we continue and augment efforts to mitigate spread of COVID-19 here in the city, and as the province moves towards reopening. And if I can, for just one more moment, if you'll indulge me a little bit more, for those of you who were keeping an eye on media yesterday, you would have seen our Board of Health chair speak from the heart on what responding to the pandemic has demanded of the entire Toronto Public Health team and beyond, and especially what it has demanded of himself and his family. So if I can, while there is still more pandemic response ahead, I would like to just take this moment on behalf of the entire team at Toronto Public Health to thank the chair for his leadership to date and for his ongoing support of Toronto Public Health's efforts to serve in this truly and very challenging time. So with that, Mr. Chair, I'll turn it over to you and to my colleagues, actually, Anania Grant and Dr. Nakoshi Lamptey, to provide us an update on the work of the vaccine engagement team.
Well, thank you, Dr. Davila and Dr. Dubé, perhaps one of the most optimistic presentations we've had in 19 months. So kudos to you and the team for bringing us to this point. Board members, we have one more brief presentation here before we move to deputations, and this is an update from Dr. Lamptey, our Deputy MOH, and Anania Grant from SCFA on the vaccine engagement teams and community immunization and mobilization plan. So Anania and Dr. Lamptey, over to you.
Thank you so much, Mr. Chair. Thank you for having me. I'm very pleased to present with Ms. Grant today an update on the community immunization and mobilization plan, which has been key to achieve the success we've had to date on immunizing every resident of Toronto who would like to be immunized. So if we can go to the next slide, please. The community immunization engagement and mobilization plan is a key part of the city's COVID vaccination program. It uses the community expertise and partnerships already developed in our community to facilitate and promote equitable vaccine uptake across Toronto to support groups disproportionately impacted by the pandemic. Social Development, Finance, and Administration has been coordinating the Vaccine Engagement Teams program in partnership with Toronto Public Health. The plan includes both a place-based approach to support residents in all 140 neighborhoods of the city and a population-specific approach to reach communities hardest hit by the pandemic. Vaccine engagement teams use measures to support groups disproportionately impacted by COVID-19, including individuals and families living below the poverty line, as well as Indigenous, Black, racialized, and newcomer communities, and persons living with disabilities. These communities experience high COVID-19 positivity rates, higher rates of hospitalization, and lower vaccination rates. We also know these communities often have experienced higher levels of emotional trauma and mental health challenges as a result of the higher COVID-19 pandemic impact. And this has also been compounded by job loss, financial insecurity, and higher stress levels, as many of them also work as essential workers. Vaccine engagement programs teams operate through 14 geographic and population-based consortiums made up of over 155 health, community, and faith-based organizations. So you can see that there's many layers of partnerships going from community members to vaccine engagement teams, organizations, and then the consortium. They use various approaches to increase vaccine confidence and access and prioritize community engagement and mobilization the reality is that the program funding for the vaccine engagement teams is slated to end in December 2021. And even as of September of 2021, many of the teams had already exhausted the majority of the funds they had been allocated. And this is because they had to support an accelerated and rapidly changing vaccine rollout in the summer of 2021, which required a lot of extensive engagement and coordination. Therefore, the need was higher than projected, particularly because the micro-local, hyper-local clinic strategy has also meant that the volume of their engagement was intense and had to increase to support vaccine clinics. If we could go to the next slide, please. So truly impressive numbers represented here. Since April 2021, they have engaged, the vaccine engagement teams have engaged over 800,000 community members, and this has involved over 350 of them. An example of this mobilization is in East York, Don Valley. Community partners there used a building-based, data-driven vaccination mapping and monitoring strategy for Thorncliffe Park. So this meant that they went door to door, engaging with people through activities to let them know about vaccine clinics. And since June 2021, this has meant that there have been 29 building-based clinics, vaccine clinics actually in those buildings where they knew they needed to be, over 16,000 doors knocked, 89 buildings reached, and 29,000 residents directly engaged, and 600 vaccine appointments booked. So truly a sense of scale that was required to meet the needs of our population in Toronto. We can go to the next slide, please. You can see that there's even some more impressive numbers here. And one of the things I want to point out is during all this work, ambassadors have been provided with ongoing training and information on COVID-19 vaccines, common vaccine concerns, and vaccine confidence building strategies from Toronto Public Health, behavioral scientists, and community organizations. With that, I'll give you another illustrative example. In North Scarborough, partners developed Operation Tam O'Shanter Sullivan in June 2021. And this was an intensive outreach campaign in high-rise apartments that had the lowest vaccination rate in that area, and they reached over 2,000 people. So truly, I think this gives you a sense of the scale and intensity of effort that has made a difference. You can see all the examples of the kinds of engagement and the scale of engagement that's happened between July and September. And we do believe that that's having an impact. Some of our latest data that we have on the rates of COVID-19 among racialized people show that there's still overrepresentation of racialized people in COVID-19 case data, but it has been a decrease over the past year. And in the end, this is all to make sure that every resident of Toronto gets the services, the outreach, and the support that they need to make the best choices for their health and the health of their family. So with that, I will turn it over to my colleague, Ms. Anani.
Thank you, Dr. Nakashi. It's been a true pleasure leading this very meaningful initiative alongside with our Toronto Public Health partners. And so I just need to say that, how important it has been and what a model we have created together in this work. But you know, we can talk forever, but what I want to do is we want to share with you the voice of. And so Dylan, if you could for us, please share with the board the video that we have prepared to hear the voices of some of our ambassadors as an example.
I'm vaccinated. Are you?
मैं टीका लगा लिया, तुसी लगा ले?
जो मैं वाकुने. E tu?
मैं दोनों वैक्सीन लगवा लिया हैं, की तुसी लगवा लिया ने?
So, emi tigba abere ajesara mi she tigba.
నేను వ్యాక్సిన్ వేసుకున్నాను, మీరు వేసుకున్నారా?
Hi,
आए मेरे दोनों नीडल लग गई हैं और आपके
أنا نعمة شمي نعمة بحال vaccination وسيدي نوصلكم خنيات كان نفسين نخبابين كدحن مالتي يغني لي I got vaccinated because I wanted to live in Canada and wanted to see my family.
So I got vaccinated because I want to go back to my country and see my grandma, my cousin, my nephew.
So the reason why I got vaccinated was so that I could go back to school and go back to my labs, which I love working in and studying in.
The reason I got vaccinated to see my family and enjoy my time with them.
I am vaccinated because of I want to go back home, enjoy the life over there. There are so many weddings, so I want to enjoy.
I'm fully vaccinated because I want to go and visit my family.
The reason why I got the vaccination because it will save my family and in my community.
I got my vaccination for the safety of others.
The reason I got vaccinated is so I can keep myself, my family, and my community safe.
I'm vaccinated. Are you?
मैं टीका लवा लिया तुसी लवा लिया
So not sure what happened there. Okay. Well, these are real people doing real things on the ground, serving Torontonians every day. Just wanted to share that with you. Dylan, if you could move to the next slide, please. So we want to talk to you a little bit about what we're seeing from our evaluation, tracking and reporting and evaluation process. At the beginning of this initiative, that it was imperative that this tracking and evaluation and reporting was a component of everything that we did. And so as we move into, my goodness, April, we're several months in, almost a year into this. It's been so important to look at how our work with engagement and mobilization continue to serve equity deserving in high priority neighborhoods. And we have been able to do some initial findings that we can share with you through our regular tracking. We have been using the tracking and evaluation to give us intelligence on how to respond almost on as immediate as possible. I would say on a weekly or bi-weekly basis. How do we need to shift? What do we need to bring forward? And we've been able to do such things as culture responsive education campaigns, the mobile clinics, translated materials in diverse languages, as you've seen. Findings to date is showing us that almost 82% of all ambassadors reported that they are engaged in door-to-doors, as Dr. Nakoshi said, in this door-to-door knocking, direct communications with residents, that they're building confidence in people choosing to take vaccine. 96% of consortium partners reported that their consortium contributed to more equitable vaccination program across their regions or focus population. The findings also identify vaccine engagement team as an effective model for place-based strategic value implementation and collaboration. For example, 82% felt that the consortiums increased the ability for community members and agencies to collaborate on large extents. 80% expressed that the level of collaboration and trust amongst consortiums increased to a large degree in development and implementation of the vaccine strategies. Community ambassadors were surveyed, and 82% of them believe the training, experience, and skill received as ambassadors better prepare them for current or future employment. This is significant. So it's not, as we are helping others keep safe through getting vaccinated, we are also increasing confidence, we are increasing skills among residents, and we are increasing collaboration. The knowledge gathered in the preliminary evaluation will help to inform the final evaluation that we will present to you in the spring of 2022. Dylan, next slide, please. And so what we want to share with you this morning, more than anything else, is that Social Development, Finance and Administration and Toronto Public Health have identified an ongoing need for critical engagement and mobilization to continue with equity-deserving groups in high-priority neighborhoods to meet the city and the province's 90% vaccine targets, and to address development challenges associated with vaccine certification, immunization of children under 12, and the provision of third dose and booster doses to those who are eligible. And so while we are seeing large numbers and we're doing tremendously well, just to see that report from Dr. Bella this morning warmed my heart to say that we are making a difference. But there are still several areas that are showing that still low vaccine rates. Taylor Massey, for example, still just slightly over 60% vaccinated. When we look at Kingsview Village, just slightly over 60% vaccinated as of October. Etobicoke West Mall, current second dose vaccination rate at 68%. It is increasing. A month ago, we were looking at 37. So what it's saying to us is that we need to continue the engagement, we need to up the engagement, and we have run out of money. Yeah? And so when we looked at what is needed as we move into next year, I'd say to July 1st, 2022, we're looking at of about $6 million is required to continue the support so that we can continue to keep Toronto healthy, raise awareness, and build a responsive public health measures and vaccine recommendations that have evolved during the COVID pandemic. Without these funds, vaccine engagement teams will be unable to continue operation beyond December 31st, 2021. As Dr. Nakashi said, they have gone beyond and above even what we have been able to fund them. They are stretching. We have over 300 ambassadors on the ground. Council Cressy, that we were just looking at 150 ambassadors when we started. We're way over 300 now. We're thinking about 350, 380. And so the need is great. And so we're not making an ask today, but I do want us to start to consider what happens after December 31st, 2021. And so I thank you so very much for allowing us to share with you today and for your continued support. Thank you.
So thank you very much, Dr. Lamptey and Anania, and to all of those in the video for their tireless work as well. Members, that concludes the presentations on this item. And so we do have 5 registered speakers here. So we're going to move to public deputations before we move it into committee for questions. So I'll, to the clerk's office, if you can prepare and get ready for that. Our first speaker is Sam Hoffman. Sam, do we have Sam on the line?
Yes, I'm here.
Sam, welcome. You'll have 5 minutes, and I'll start your clock when you're ready, and you can begin at any time. Thank you for being here.
Thanks for having me. Hi, everyone. I've also made a written submission on behalf of 30 parent-led groups across the city who either are still running, were running, or were planning asymptomatic testing program using rapid antigen tests. Now, some of these other groups are in schools that have had many school-related cases, either this year or last, up to 20 cases, about the middle of our experience in Toronto. But most of the highest risk schools in the city have not, to my knowledge, had any asymptomatic testing program set up yet. Since the province shut down our test supply, the current situation is that nobody, except for businesses, can access the tests. However, as you know, the provincial announcement made October 5th gives public health units access to rapid antigen tests to be used in high-risk schools to be defined as the PHU sees fit. To put things very clearly, for anyone other than businesses, like it or not, You and other PHUs are now the gatekeepers of the province's supply of rapid tests. I'm here to urge the board and public health to move quickly on this opportunity. It's been 3 weeks since the government's announcement. I have not heard of a single asymptomatic testing program being set up in the city. Respectfully, the Silverthorne CI program announced last week is a reactive half measure. It's temporary, as I understand it, and it's really just a cleanup after an outbreak. Take-home PCR tests are also helpful, but they're for kids with symptoms or known exposures only. Testing programs should aim to prevent or to limit the size of outbreaks before they are detected, and to be able to detect pre-symptomatic and asymptomatic cases, which we know are very common in children. I would urge the Board of Health to think of asymptomatic testing of children as a critical public health intervention within your reach. We know that kids aged 5 to 11 are currently the age group with the greatest incidence rate, both across the province and in Toronto. We also know that they are all unvaccinated, meaning they are completely unprotected from contracting, transmitting, and potentially having either acute or long-term consequences like long COVID. Now, I understand that many people, including public health authorities and school boards, like to say that schools are safe and that most school-related cases do not transmit in school. I beg you to refrain your consideration of the effects of a school-based testing program. If you want to control a disease, you try to find and prevent transmission in the accessible chunks of the population that are contributing to its spread. School-aged kids are a highly accessible and concentrated population, which account for a large amount of COVID transmission. Whether they get COVID from a sibling at home, from a friend on the weekend, or at an after-school program, testing in school-aged kids can identify either at home, on the weekend after school, or even in school. And if you want to prevent any kid from getting COVID in the first place, you can also provide tests to their family members and other close contacts. Unvaccinated kids live in and are parts of our community, and they are vulnerable. Now to address some possible objections. The tests are not too hard to use. Anyone can be trained to use them with a pamphlet or a video. There will not be too many false positives. Less than 1 in 1,000 tests. How many kids are kept home from school because of symptoms every day? False positives would be a tiny increment to the already existing disruption. Programs are not too expensive or complicated to administer. You can simply give every kid a box of tests and some instructions. Send them home with the kid from school. It's worth it. The tests have already been purchased. Incidence is high in this age group. We can expect more cases as the weather turns, and polls predict low vaccination uptake among kids. We may still have to worry about unvaccinated kids and COVID for some time. A final objection may be that uptake for these programs will be too low. Well, frankly, it does take time to grow programs, to make testing a part of routines, create community buy-in, create a social norm around testing, get the message out that it's something we can all do to help each other. It's a great opportunity for the kind of place-based collaborations that we just heard about, and it's all the more reason to start testing right away. To conclude, tests sitting in warehouses do nobody any good. Please get them out there where they can be of use. Thank you.
Thank you very much, Sam. Let me stop there and open it up to see if there are any questions for you from members of the board. Just looking for hands. Seeing none. Sam, thank you very much for your deputation and the written submission. Thank you kindly. Our next registered speaker we have is Derek Moran. If I could ask if the recording or the clerks could connect Derek, please.
Hi, can you guys hear me?
Welcome, Derek. You'll have 5 minutes and you can begin when you're ready. Thank you.
Just going to start my timer here. I just want to say by me speaking at this meeting, this shall not be deemed to be in any way my consent expressed or implied. In doing so, it's fraud. God bless Her Majesty the Queen and long live Her Majesty the Queen. I want to start off by thanking Councillor Wong Tam for the question last month she asked of Western University Professor Donald Welsh, who specializes in cardiorespiratory biology, to explain to her what he meant specifically when he referred to COVID vaccines as being leaky vaccines. Just to refresh everyone's memory, Professor Welsh stated, so a kind of a traditional vaccine, that's something that we think of in the back of our minds as it's an agent, a biological agent. that blocks the infection process, blocks the disease process, and then also blocks transmission. Now, respiratory vaccines, that's what we sort of call them. They don't effectively block either the infection or the transmission over long periods of time. What they do is they tend to moderate the severity of the disease. Because they don't do all three of those, we tend to call them leaky. And that leakiness has consequences into the future. It can often promote variant development or mutations. And those mutations can often get around the normal, let's say, viral defenses of your body or induced by a vaccine. So as I understood this, Professor Welsh basically explained, at least to me, that it's the COVID vaccines themselves that are leading to mutations that are leading to the variants of the virus. But the same as I expect from Dr. Davila to provide the science to the public, I would expect the same of Professor Welsh and ask if he could simply share with the rest of us on his Twitter page, for instance, the peer-reviewed studies that back up his claims he has made about leaky vaccines. And Dr. Davila has said that her decisions are based partly on evidence such as the scientific literature. So I came across this article from the scientific literature, in this case, the NCBI, the National Center for Biotechnology Information, and I provide the link and screenshot in my written presentation. It states, COVID-19 vaccines designed to elicit neutralizing antibodies may sensitize vaccine recipients to more severe disease than if they were not vaccinated. Vaccines for SARS, MERS, and RSV have never been approved, and the data generated in the development and testing of these vaccines suggest a serious mechanistic concern that vaccines designed empirically using the traditional approach consisting of the unmodified or minimally modified coronal viral spike to elicit neutralizing antibodies, be they composed of protein, viral vector, DNA, or RNA, and irrespective of delivery method, may worsen COVID-19 disease via antibody-dependent enhancement, which is also known as ADE. The risk is sufficiently obscured in clinical trial protocols and consent forms for ongoing COVID-19 vaccine trials that adequate patient comprehension of this risk is unlikely to occur, obviating truly informed consent by subjects in these trials. I provide another link and screenshot here from the NIH, National Institutes of Health, which states, one potential concern about COVID-19 vaccines is an unusual phenomenon called vaccine-associated enhanced respiratory disease, or VAERD. VAERD, VAERD, can occur when a vaccine induces an immune response that causes the disease the vaccine is supposed to protect against to be more severe if you're exposed to the virus. In my written presentation, I provide a link and screenshot from the Public Health of England, which shows that those who were double vaccinated were almost 4 times greater of dying from the Delta variant than those who were unvaccinated to begin with. This data
Derek,
also shows...
just a heads up that you have about 20 seconds left. Thank you.
This data also shows that 70% of the deaths in this time period due to the Delta variant occurred in those who were vaccinated, and especially of note, 63.5% of the deaths occurred were in those who were double vaccinated, and that's my time.
Thank you very much, Derek. Let me just open it up to members of the board to see if there are any questions for you. Seeing none, Derek, thank you very much. Our next speaker, if the clerk's department could connect them, is Margot Boyd. We have Margot on the line.
To the chair, this is the host. Margot is currently connected and unmuted. Margot, if you are present, please speak.
Margot, do we have you there? Margot, if you want to try speaking, we'll come back to you in a moment to try again if we don't have you. But Margot, just the last time to see if we have you there. Okay, so we'll hold down Margot. I'll try to come back to see if we can resolve any tech issues there. So Margot, we will try to come back to you. And I'd ask the Clerk's Department to try to work with Margot to resolve that. Our next speaker is Kelly Brown. Do we have Kelly on the line?
Hello, everyone.
Hi, Kelly. Welcome. Thank you for joining us. You'll have 5 minutes, and you can begin when you're ready. Thank you very much.
Okay. Chair Cressy, members of the Board of Health and City Councilors, Medical Officer of Health, Dr. Davila, members of the media, fellow attendees. My name is Kelly Brown, and I speak to you today in a personal capacity as a citizen. Thank you to the board for its stewardship during these last 2 years. Today, I will update the board regarding Public Health Ontario's latest data on post-vaccine myocarditis incidence, which continues to show troubling increases. By way of background, I am a career financial professional, a former Bay Streeter with experience in investment banking, private equity, and public markets investing. My successful career I attribute mostly to competency in data analysis, intellectual curiosity, and critical thinking. I am not a doctor nor a scientist, so I will restrict my presentation to data reported by government sources, Public Health Ontario and Toronto Public Health. I will make no unreasonable inferences nor any future predictions. Therefore, what I have to say cannot be dismissed as misinformation. As of the last meeting of this board, Public Health Ontario reported approximately 400 cases of post-vaccine myocarditis, half of which occurred in males aged 12 to 29. In the 4 weeks since, Public Health Ontario has reported an additional 66 cases, with 40 of those occurring in 12 to 29-year-old males. There are now approximately 230 myocarditis cases in this one age-sex cohort, occurring at a rate of 1 in 6,000 males. Post-vaccine myocarditis risk increases as the age category decreases, and considering only 12 to 17-year-old males, the risk is closer to 1 in 5,000 males. These boys are receiving Pfizer. Dr. Kieran Moore, Ontario's Chief Medical Officer of Health, on September 29th, addressing the Pfizer over Moderna recommendation, indicated, quote, "Even in the phase 3 trials of the major vaccines, we didn't see any signal for myocarditis. It's only when you have adverse event following immunization reporting that you find these very rare events," unquote. As a reminder, Pfizer's global trials included less than 2,000 children aged 12 to 17 globally. Ontario's young boys and men should not be treated as involuntary trial participants and deserve better protection for their chief medical officer of health, who has been cavalier in his support of mandatory COVID-19 vaccination in these young ages. The post-vaccination risks outlined above far exceed the risk of ICU admission or death from COVID-19 infection in these young ages. Regarding the risk of COVID-19 associated myocarditis, at the last Board of Health meeting and subsequent City Council meeting, Dr. Davila stated that the risk of myocarditis was much higher following COVID-19 infection than after vaccination. However, quality data supporting this assertion is lacking, and studies on this topic only emerged to any degree later in 2021 after we began vaccinating young members of the community. If COVID-19 associated myocarditis was observed to a troubling degree during the pandemic, it is likely more alarm would and should have been sounded. To my knowledge, definitive age-stratified data establishing a clear causal and temporal link between myocarditis and COVID-19 infection in Ontario has not yet been presented to this board or to the public to support Dr. Davila's assertions. As a broader point, we should not have to choose between the lesser of two evils. We should demand absolute levels of safety from vaccines. The serious adverse event rate for all vaccines given in Ontario in the last decade was 1 in 170,000. As mentioned, young boys face a 1 in 5,200 myocarditis risk after the Pfizer vaccine. In closing, it seems that this board continues to ask young boys and men who have their entire lives ahead of them to take known and quantifiable risks for little or speculative benefit. As a professional investor, All my key actions are based on rational and data-driven analyses of costs and benefits. Risk reward is the name of the game. In my line of work, if I miscalculate, misjudge, or inadequately balance risk and reward, I stand to lose only money. However, in public health, if miscalculations are made, members of the public can suffer real, unnecessary harm to their person.
Kelly, just a note, you have about 10 seconds left. Thank you.
Vaccinating young boys and men for COVID-19 is a bad trade and should be halted immediately.
Thank you very much, Kelly. Let me just open it up to see if there are any members of the board with questions for you directly. Seeing none, thank you very much, Kelly. We will now try to go back to Margot Boyd. I'd ask the recording secretary, do we have Margot on the line?
Hi, can you hear me now?
We can. Welcome. Glad we got that sorted.
Oh, great.
Margot, thank you for the patience and for sticking with us. You'll have 5 minutes and you can begin when you're ready.
Thank you. My name is Margot Boyd. I have a postgraduate degree in health sciences from what is now known as the Della Lana School of Public Health at U of T. My area of interest was the determinants of health, and I grew to understand the imperative that policy must be data-driven and evidence-based. During the 90s, as a young graduate, I had a brief stint as an intern at the Ministry of Health and then worked at 3 different hospitals on University Avenue. I have since retired and work in the area of ethical advocacy. I wish to make it perfectly clear that I am pro-vaccine and not an anti-vaxxer. I am speaking to you again today because it is over the past months I have observed an increasing gulf between what the data is telling us and our COVID-19 health policy. My colleagues in the healthcare system may not speak out at your meetings for fear of reprisal and losing their jobs. They are conspicuous in their absence, but nobody can fire me. There's been no room for dissension within the public health narrative. No research or counter-opinion is tolerated, which, as you must know, is antithetical to the progression of science. Discourse is paramount. We must hear the evidence that deviates from the dominating and accepted narrative of public health. Otherwise, we miss out on important information and make irreversible mistakes that cause devastating accidents that never should have happened. Ironically, the first place you can look for evidence counter to the public health narrative is within public health's own data set. It is fair to state that they have ignored their own data. If I were a city councilor, I would be asking public health some tough questions. For instance, there was no presentation of data provided along with the agenda for this Board of Health meeting. Where was the breakdown of adverse events by age, sex, and brand of the injection they were to deliver so that we could comment on it at this meeting? Presentation of information, as was done today in a walk-in style by public health, does not allow for either questions or counter-arguments. Why did this happen? If I were a city councilor, I would ask, what about data from other countries? For example, why are the Scandinavian countries stopped with the second vaccine of 12 to 17-year-olds, and in Sweden stopped all Moderna jabs to anyone under the age of 30? In light of the international data set, why are we now forging ahead to repeat their mistakes? If I were a city councilor, I would ask why there appears to be an actually negative protection rate of the vax against COVID-19 in both the Israel and UK data. I would ask them to explain why the latest UK data set shows a negative protection rate in the 30 to 80 plus years age groups for cases. Why do the vaccinated now present with COVID at a higher rate than the unvaccinated in both Israel and the UK? And why, with all their own and internationally accessible data, does public health choose to condemn us with repeating others' mistakes? I would ask public health, why don't you change course in the face of this new data? And I would ask, why has public health recommended with various motions for City Council to put Toronto and Ontario on a collision course with already known devastating health consequences for mRNA injections in children? Who benefits? I would also ask public health why they now state that COVID-19 actually causes myocarditis in children. We know that this statement has no basis in fact. Sick Children's Hospital set up a clinic for children who have gotten post-jab myocarditis this summer, 2021. There was never any need for a children's myocarditis clinic for well over a year after COVID-19 began, only when the injections commenced. In fact, a cardiologist who receives cardiac referrals from sick children who shall remain nameless to protect them from the CPSO, stated they had seen 0 cases of COVID-19 caused myocarditis in children. A false narrative was generated. Who benefits? This situation is serious, as the well-being of children hangs in the balance. We are no longer inoculating the vulnerable and the elderly who make up the vast majority of the COVID-19 fatalities. For some reason, the Board of Health, are choosing to jab a population which the evidence shows does not get severe COVID disease, does not die from COVID, and does not spread COVID because of their low viral titers. The inconvenient truth is that there will be irreversible damage and fatality in the children resulting from mRNA jabs if you do not change course and follow the actions of other countries that have modified and withdrawn injections as a result of internationally known and recognized data. Just like Dr. Moore removed Moderna from the male 18 to 24 age group, he will have to remove it from the 12 to 17 age group after we see the heart damage we know will occur according to available evidence. Public Health has
Margo,
done
you're
the public...
just coming up on 5 minutes. If I could ask you to wrap up in a sentence, please.
Oh, okay. I'll 2 sentences. Public Health has done the public a tremendous disservice by not telling parents that their children have an over 99.99% infection survival rate, having chosen instead to fearmonger and frighten them into jabbing their children with products that have already been withdrawn elsewhere in the world. Why?
Thank you, Margo.
Thank you so much for your time.
You're just at 5.5 minutes. Thank you very much for your presentation.
Thank you so much.
Let me just open it up to see if there are any questions for you directly from members of the board. Seeing none, Margo, I thank you. I'm glad we were able to resolve the technical issues. We have two more speakers on this item. The first is Dr. Donald Welsh, followed by Tenzin Wagmos. Do we have Donald on the line?
Yes, thank you.
Welcome, Donald. You'll have 5 minutes and you can begin when you're ready. Thank you.
Great, thank you. Pleasure to address the Toronto Board of Health. My name is Dr. Donald Welsh. I'm a member of the Robarts Research Institute and professor of physiology at the University of Western Ontario. My specialization is cardiovascular biology. I publish in peer-reviewed journals, and I currently hold 4 federally funded grants. I would like to take a small portion of your time today and provide broader context on respiratory biology, viruses, and applications to children. The lungs are responsible for oxygenating your blood, and for proper gas exchange to occur, your blood must come into close contact with the air. Now, respiratory viruses, and there's about 200 in free circulation, often lodge in your lung. They initiate an infection and inflammation, and they interfere with this gas exchange. In a small number of these cases, the infection can spread to the body, leading to serious life-threatening conditions, particularly in the highly vulnerable. Viral infection happens 24/7, 365. Most of you barely notice because your lungs' mucosal immune system destroys the virus quickly, and this is especially true in children. Mucosal immunity is distinct from your acquired immunity, which is mainly found in your circulatory system. Now, the severity of respiratory viral infections are age and risk stratified, and thus vaccines are typically deployed in a similar risk stratified manner. Note that respiratory vaccines aren't true vaccines in the sense of completely blocking infection, disease, and transmission. They should be viewed as time-limited therapeutics designed to moderate disease, and they're one of several tools we often use in a larger toolkit to counter respiratory viruses. CoV-2 is a new coronavirus strain which follows this stratified pattern even more so than usual. Pre-existing immunity exists in the population, especially young children, the latter being of exceedingly low risk to hospitalization and death, and some experts even use the words close to zero. This brings us to childhood vaccination of 5 to 11-year-olds and the new generation of CoV-2 vaccines. Given this group's exceedingly low risk of hospitalization and death, the rationale for mandatory vaccination is weak and counter to the principles of precision medicine. Further, the side effects of vaccine deployment, often termed vaccine injury, must be considered. While most are often mild. Injury in rare instances can extend to death. This is problematic for childhood risk-benefit calculation, as serious outcomes are also remarkably low. Vaccine injury is a topical issue, as given the marked prevalence of myocarditis in young males, and this concern heightens at younger ages. And this is given the fact from what we know from past vaccine deployments. Whilst COVID-19 vaccines are especially prone to this phenomenon, we don't really know why, but we should consider dosing as an issue. Without going into the details, this isn't a trivial issue for new genetic-based vaccines. So while dosing remains an issue for childhood vaccination, there are additional concerns, the most important being that the immune system of a child is distinct from an adult. They rely more on lung-based mucosal immunity than the acquired immune system, the latter of which is being trained by natural infection and often vaccines over many years. There is concern, especially with the COVID-19 vaccines, that pushing early development of acquired immunity could weaken lung-based mucosal immunity in children. This could be deleterious, and it is why we should be very cautious of a one-size-fits-all approach to vaccination. Unintentional consequences will and do occur. As a final point, I wish to express concern as to the odd response to C19 vaccination. The entire process has taken on a strange kind of air of a shifting human experiment, with key parameters changing weekly. This is less than ideal, and it's reflective of probably the compressed timescale of clinical trialing.
Donald, just want to note you have about 15 seconds left.
Sure. I appreciate time is short, and there is more nuance to my arguments. And in this regard, I extend once again an open invitation to all of you to discuss the topic in greater detail. I'm available anytime that fits your schedule, and thank you for your time and consideration.
Thank you very much, Donald, and appreciate the patience. Let me open it up to see if there are any direct questions for you from members of the board. Seeing none, thank you very much, Donald. Our final speaker on this item is Tenzin Magmo. Do we have Tenzin on the line?
Yes, I'm here. Thank you so much.
Welcome, Tenzin. You'll have 5 minutes and you can begin when you're ready.
Okay, perfect. Thank you. Good morning, everyone. I hope you're doing well. Thank you for this invitation to speak today about my experience as a vaccine community connector. I'm honestly truly grateful for this time and looking forward to the conversations. My name is Tinsley Womo. I'm currently a vaccine connector for the Downtown West area with Parkdale Activity Recreation Center. And apart from this, I'm a full-time political science student, a community organizer in the Tibetan community across Toronto, as well as the Ontario Tech campus. Over the course of months, I've had various opportunities to engage in various communities in the Downtown West area, such as Trinity, Parkdale, Fort York, Staddingport, and much more. It's been so fulfilling to see impacts unravel and that continues to create the impact. So this work has allowed me to bring forth, such as direct change within the community and understand first-handedly the experience of audiences from various backgrounds. And with this, I can tell you that firsthand, the community members who are supporting their neighbors to access and learn about the vaccine are the front lines of an extremely challenging situation. People are scared and uncertain of the right thing to do and often face multiple barriers to get to a clinic. It is difficult to understand the full impact of this work unless you've spoken to someone for hours or even a long period of time and slowly then seeing them move from a place of fear to asking questions about how the vaccine works, its benefits, and how they can finally get it. I once spoke to a man who I could see who changed his mind after his experience, and he felt safer and encouraged to talk. Finally, I walked up to him during the pop-up clinic after hours of just standing there, and he finally got his vaccine and gave a thumbs-up gesture to his wife, who was looking down from him from their apartment window. This was a bittersweet moment, and it showcased how the sense of community and accessibility increases the engagement from the public. With all the vaccine connectors and ambassadors are doing at clinics, they often are not supported by multilingual informed teams and medical experts that could answer people's questions in real time. This is, of course, during the outreach and during walking outreach and just engaging with the community members directly. So healthcare workers' support on site providing information would bring more legitimacy and may clear up the assumptions and doubts that the public has. Some of the solutions I see is more funding within hours so that ambassadors can fulfill more hours at different clinics and continue to promote that willingness to help without the thought of that they have limited hours to spare. And another is continuing to give incentives to various communities. And this was also heavily asked by a lot of the public audience. Also more vibrant locations, increasing materials and props, more accessible pop-up clinics in various vulnerable communities, as well as language team, a language multilingual team that is pre-planned before attending vaccine clinics and creating these vaccine clinics. And with children being the next group to receive the vaccinations, more parents will want to seek more safety and dialogue with healthcare workers. So as mentioned before, the involvement of healthcare workers would be very beneficial. I believe the work must continue, and I implore this table to consider a robust funding budget. Community members answering the call to do this work continue to put themselves in unknown and uncertain situations. They are brave, and their impact of work is immense. They need to be honored with intentional and robust supports that center their safety and support their success. Thank you all so much for this opportunity, and I would also like to extend my deepest gratitude and thank everyone for their contribution to helping improve the city. There is immense work behind the scenes, and I want to acknowledge and thank all the staffs and coordinators. I hope to do my part, and I look forward to the year, and I hope we can all maintain this momentum as Aline mentioned. Thank you so much, everyone, and better together. Thank you.
Thank you, Tenzin. Better together is a lovely way to conclude public deputations. Let me just see if there are any questions for you directly from members of the board. Okay, seeing none. Thank you to all our members of the public who deputed. We will now move this into committee for questions of staff. I have Trustee Donaldson. I'm just doing a show of hands to see other members of the board who have questions. Councillor Fillion. Just going to come up with like an honorary chair title or something, given your history here, Councillor. Director Mulligan. Okay, I have Councillor Perks. We'll get started with that, and then if others have questions, we'll proceed. So, Trustee Donaldson, over to you.
Thanks, Chair. Sorry, I was having a little trouble getting it off mute. So my questions are on the first presentation, but very grateful for both, of course. I just want to start by saying thanks as always to the team. I agree with the chair. This is one of the most optimistic presentations we've seen in a very long time. And I'm grateful to every single staff member of Toronto Public Health who have moved mountains to bring our city to where we are now in the fight against this virus. I also want to particularly thank Dr. Vinay Dubé and Nicole Welch, who have been so instrumental in keeping our children and youth safe and well, and their truly effective partnerships with their schools in this city. As a school trustee, I've witnessed again and again and again how responsive and effective they've been in our education sector, and it means the world. So my questions, and I have a few, starting on slide 7, the vaccine planning slide. So with respect to the vaccine strategy for 5 to 11-year-olds, I'm hoping that you can please describe what a needs-based approach looks like, so families can understand a bit more what to expect in terms of access to the vaccines in their immediate communities. I'm sure, as you can well imagine, there are many, many families who are eagerly awaiting these vaccines. Thanks.
So through the chair, why don't I start off? And if Dr. Dubé has anything further to add, I'll let her add. At a very high level, when we're talking about a needs-based approach, we're actually looking at those communities where we know there has been more challenge in respect of COVID-19 and its impact, and where there are coverage issues in respect of existing COVID-19 vaccine amongst those who are eligible at this point in time. As well, we also have to think about getting access for people and making sure that the access points meet the needs of individuals and families. So ensuring that vaccine is readily available and that it is directed towards those neighborhoods that have been most impacted by COVID-19 and where we expect that it will have the greatest protective benefit in the first instance is part one. The other part, of course, is around making sure that vaccine access points are suitable for a broad range of individuals and families. So whether it is through mass immunization clinics, mobile pop-up clinics in the neighborhoods where people live and where the rates have been higher or where the impact has been greater in terms of COVID-19, pharmacies, local community-based clinics, physicians and or other healthcare providers, offices, hospitals are supporting with us with this work. School-based clinics may make more sense for certain populations. So it's a variety of channels, but directing the resources as much as possible in keeping with the data as we see it on the ground.
Thanks. And so with respect to timing, I'm hoping that you have an estimate. The last Board of Health meeting in September, you mentioned that Toronto Public Health staff are working to be prepared for the beginning of November, which is only a number of days away. And I appreciate Dr. Dubé's briefing on the vaccine approval process. And I understand that Health Canada does need to carefully review the safety and efficacy of the vaccine for children. So with that in mind, is there a rough timing estimate for when the vaccines might be available in our city for our kids?
So through the chair, I'll start off again with this. Trustee Donaldson, a couple of things. One, we know that Pfizer has put in a submission to Health Canada, and so that review process is underway. But again, I can't speak to what will be required and how soon they'll be able to complete their review process. We also heard on a positive note that the federal government has successfully procured vaccine, but actually the logistics, as it were, of getting the vaccine, then getting it to the province and getting it to us is not really within our control. My hope is that as things proceed well, we're hoping in the next few weeks, but I don't want to try to predict something that frankly we don't have any control over, nor can we really predict what will happen, at other levels of government. So our planning continues. We have every intention of being ready, and we're just looking forward to that opportunity to provide this protective benefit to kids.
Understood. So my last question is on slide 12. And it's the slide discussing the impacts of paused work due to COVID-19. And thinking about children and youth in particular, I find this to be a bit of a concerning list. I see school health, healthy growth and development, oral health, etc. on this list. So I guess my question is, does Toronto Public Health have the resources it needs to address these essential functions as soon as possible? Or is there a threshold, for example, city vaccine coverage that you're looking to meet before you redirect the resources? How does this work? Thanks.
So through the chair, very deep question, lots of elements here. At a very high level, we are trying to provide services outside of the COVID-19 response where we can, and in keeping with what we have done previously in emergency preparedness and response, right? You have prioritized programs that can't really stop without getting some immediate health impact and creating serious health problems. I don't know that I have a very definitive answer for you, Trustee Donaldson, to be quite, upfront. There's still a lot of pandemic response that has yet to be affected and put into play. And I think the other challenge, of course, is that We do need to provide people a little bit of an opportunity to decompress from the response before, we can turn back on all the programs as they were before. On top of that, we have yet to see, what might we anticipate in terms of the cold and flu season? What sort of impacts might there be? And we're still not out of the woods yet. We have seen in other jurisdictions, even in those jurisdictions that have pretty high vaccination coverage rates, that as some of the measures are let go, that cases do rebound, and there are new variants that are emerging, and which we're still studying. There's lots of learning still ongoing here. So I can assure you that we will continue to monitor and observe. And as we hopefully continue to maintain the progress we've had to date, we will work towards recovery and restoring some of our other programs in a prioritized fashion, though, right, in keeping with the resources that we have. And of course, we'll continue to report to you as the board on what that looks like.
Thanks very much. I appreciate that. And as a member of the board, I also appreciate the transparency. We're all in this together. So very grateful. That's it from me. Thanks, Chair.
Thank you, Trustee Donaldson. Next, I have Councillor Filion.
Thanks very much, Dr. Davila. My first question sort of relates to who is getting COVID now, how they're getting it and where they're getting it, and especially in relation or in light of the province's announcement that they may be eliminating mandates as soon as January. So I have been kind of assuming that most of the people who are fully vaccinated who get COVID are catching it from the unvaccinated, but do we have any data on that?
So through the chair, Councillor Filion, I don't know that we can tell you in every single case. We are seeing that younger people are getting impacted by COVID, certainly in terms of the case numbers. But with respect to the most serious of outcomes, that tends to be affecting an older population, and particularly those who have pre-existing medical conditions. We know there are still a significant number of people within our community who are not vaccinated or are only partially vaccinated, and they certainly constitute a big reservoir of the potential source of transmission and infection. And we've certainly seen that at last Board of Health meeting. I spoke to a particular example of a household where an unvaccinated adult spread to the entire household, and that then had subsequent impact on a number of different schools in the community. But certainly, Councillor, I would refer you and members of the public, of course, to our dashboard where there is information. And again, as people are out and about and moving, it's not quite so simple to specifically identify in every case what the source of infection is. We have risk factors and we record that information as best we can. But with more and more movement, it is difficult for people to ascertain and to provide the necessary information to make a clear determination.
Sure, I guess it's, I can understand the difficulty. I'm just not sure how concerned we need to be about the province's thinking or about polling that would indicate that parents of younger children may be more hesitant to get vaccinated. In relation to the spread, is there some way we can do better tracking of that?
Well, through the chair, Councillor, what I can speak to is the recent modeling that was put out by the Ontario COVID-19 Science Advisory Table. And their modeling and ours, what we have been able to do as well at the city level, suggests that the strategy is to continue to encourage vaccine uptake and encourage vaccine uptake amongst the youngest members of our community as that opportunity hopefully becomes available soon. And of course, to continue public health measures including that masking and distancing, as we know that does make a difference for transmission. I think we are still very much, with this relatively new virus, still learning quite a bit. We have not had a fall and winter season with a more vaccinated population such as we have right now. We do know that moving indoors does create for conditions where people interact more indoors. The cold weather creates for conditions where people interact more indoors, and the transmission is certainly facilitated in that environment. So I think we have to monitor very, very carefully, both here at the city and at the province, and act quickly, knowing what we know now and implementing the lessons we've learned over the course of the past almost 2 years now.
In a worst case scenario where the province moves ahead with deregulating and you disagree with that, am I correct that you would still have the authority, although we know that we'd rather have the province use theirs, but would you still have the authority to continue those mandates in the City of Toronto?
So through the chair, there are certainly some powers that can be exercised under the Health Protection Promotion Act, and there are certainly powers that the city may have. And again, I'm not a lawyer, so I don't want to go too far, but what we've seen thus far is the application of powers of the local medical officer of health under the Health Protection and Promotion Act, and bylaw powers that the city and council would have to enact. I think that what the appropriate course of action would be in the future will depend on what the specific circumstances are. Powers under the Health Protection and Promotion Act must be exercised with certain provisions being met. One has to have grounds for exercising powers under that act, and we'd like to make sure that we're judicious in the use of those powers and appropriate in the use of those powers.
Just coming up on 6 minutes, if that's all right, Councillor.
Yes, thank you. I have other questions, but I'll stop there. Thank you.
Thank you very much, Councillor. Next on the list I have is Director Mulligan.
Thank you, Chair. I have some more questions about schools as well. Dr. Davila, at our last meeting, you noted that there was an increase in the number of cases amongst children 5 to 11, but it was a bit too early to say, whether that had anything to do with back to school. You recommended that we check in again at this meeting, so that's what I'm doing. But I didn't hear it in your update, so I'd like to hear your if you have any data about what's happening with case rates in that age group.
So I may just turn to my colleagues who are joining me on the call. Certainly we are seeing, high rates amongst those who are unvaccinated, and that would include the youngest members of our community. However, I think in general, what I would say is that we've been pleased to see that we haven't seen a huge upswing. I mean, clearly the overall metric and indicators are trending in the right direction, even though we are now towards the end of October and well into the fall return to school. I'm not sure whether, Vanita, there's anything further you'd like to add. I see your hand up, so I'll turn it to you.
Yeah, sure. Thank you through the chair. Actually, we've seen, as Dr. Davila mentions, our overall case rates go down, which is really fantastic since schools have reopened. We're also noting that our daily outbreaks or outbreaks in schools are lower. They're about 15 through last week. So they are, again, outbreaks are by definition where someone could have reasonably gotten COVID in the school setting. 15 schools out of 1,200 schools. So that, again, is a number to keep in check. The other number to give you is that on average, each outbreak since school started in September has 3 cases associated with it. So I think that's another really important metric to note, that despite the Delta variant, despite elementary schools that have mostly unvaccinated students in them, even though there are outbreaks, they're fewer. The outbreaks themselves are not very large. And again, speaking to those layers of prevention that are occurring in schools, continuing to play a mitigating role. Thank you.
Okay, thank you so much. That's quite heartening to hear. And I'm really pleased to hear the update about that. Dr. Davila, are you aware, are there some schools that are doing asymptomatic testing using the PCR tests that they have been provided by DPH?
Vanita, do you want to pick that up?
Sure, yeah, thank you. So last year, Toronto Public Health had an asymptomatic testing pilot that we, PCR testing pilot that we implemented with the Ministry of Education along with the testing partners. That subsequently came to an end because even despite the fact that that testing occurred, for example, at the beginning of the year into the spring when we had a lot of COVID, wave 2, wave 3, the asymptomatic testing pilot did not find a lot of new cases beyond our symptomatic testing, case and contact follow-up, close contact testing. There currently, provincially, is no criteria allowing for routine asymptomatic PCR testing in the provincial testing guidelines, which is what we do follow. So if it were to be done, it right now is considered research, so to speak, is not currently allowed on a broad scale on a publicly funded basis. That being said, we make a lot of asymptomatic testing recommendations in the school and otherwise. So again, to remind you, a dismissed cohort, they are all recommended to be tested twice with a PCR test, and that is mostly asymptomatic testing.
Thank you, Dr. Dubé. So that means, so if you're a parent and you find in your school, in your kid's backpack, they've been sent home with a PCR test, the implication is that there has been an exposure in their classroom. Is that correct to assume?
Through the chair, I think I would hope that it would be more than just a test kit that would get sent home in the Backpack Express, and that there would actually be some information on why the testing is recommended. Certainly, Toronto Public Health works with the school boards to provide information to parents in dismissed cohorts. If a cohort has been dismissed, if a student is unvaccinated, they're actually also required to stay home, as well as the recommendations for testing. It's only if they're vaccinated that they continue to attend school. So I wouldn't certainly recommend that parents make assumptions on why a test kit has been sent home, and would certainly seek clarification from the school, because the schools have been very good about providing communication on behalf of Toronto Public Health and with Toronto Public Health to parents.
Thank you. And I just have one last question. I'm hoping that that one or both of you could provide an update for us about the science of whether COVID is airborne and what, if any, precautions might need to be taken with respect to ventilation and so on as we head into what you call, Dr. Davila, the season where we're starting to head indoors.
Would you like me to answer that, Dr. Davila?
Why don't you go ahead, Vanita? I'll jump.
Okay, just to say that we certainly do recognize and have recognized for a while now that COVID can be spread through aerosols. And so predominantly what we are still finding that the predominant way, especially in children, that children are getting COVID is through close contact, often with someone in their house who has COVID. And that's often that close contact droplet spread when we're talking, coughing, sneezing. But when we're doing those activities, sometimes the droplets can get suspended in the air, the smaller droplets, and they can be aerosolized. And so that's the type of spread that can linger in the air, and for which measures like ventilation in the school setting can be particularly important, and certainly something that we recognize and we continue to recognize, and that schools have, in fact, many Toronto schools, most classrooms have access to a HEPA filter if they do not have other ventilation measures in place, including the right-sized HEPA filter for the size of the space as well. I'll turn it back to you, Dr. Davila.
Yeah, the only other thing I would add to what you've already said, and thank you, Dr. Dubé, for that, is that this is just another example of one of those things where the understanding, right, and the science continues to evolve, and there is still more study. So recognizing that we are a local public health unit, we are, basically the recipients of much of this science and understanding, and to the extent that those authorities or agencies who are more responsible for taking care of this continue to update the information, we will certainly share it with you and, of course, with relevant stakeholders, whether it's within the school setting or otherwise. As the knowledge evolves, we're also updating the information and the guidance that's being provided as a result.
Thank you so much.
Thank you, Director Mulligan. Let me just open up to see if there's any members of the board who have not yet asked questions who may have any. I just have a couple very briefly, and to the clerks, you can start my time. Dr. Davila, just very briefly on 5 to 11-year-old vaccine planning. With the news we heard from the feds last week that they are procuring enough supply for this whole age group across the country. Does that mean we can now, at the local level, plan on the basis of there being supply for all who need it, as opposed to a prioritized supply model like we started with last spring for adults?
So through you, Mr. Chair, my understanding is yes, that we should be able to plan for all. But of course, the proof is always in the pudding. We need to actually get the product in order to be able to deliver it on the ground.
Okay, and in our planning, so assuming that we get the product for all as we hope, Trustee Donaldson was asking a bit about this. Is the model we're working on that every eligible 5 to 11-year-old would be able to book an appointment, but that there would also be a concurrent targeted strategy for those hard-hit neighborhoods? So everybody can book an appointment, but specific targeted accelerated work in hard-hit areas. Do I have that correct?
So briefly, through you, Mr. Chair, yes. And of course, we're trying to make sure we're providing services in a manner that meets the needs of all populations, and particularly meets the needs of different families and different circumstances.
All right. And then on the vaccine engagement teams, perhaps this is best to Dr. Lamptey, but Dr. Davila, you jump in as you see fit. Dr. Lamptey, you and Anania provided a really comprehensive and powerful presentation about the value of this community-based work. Do we see the value in this work as we now look towards both 5 to 11-year-olds and third doses? Is this going to be a critical and necessary part of that next stage of this rollout?
Thank you, Mr. Chair. In a short answer, yes. I think it will be valuable because we do find that there is a relationship between adults' perception of the vaccine and then their perception of the vaccine for the children and their family. So where we have seen higher levels of hesitancy in certain communities, we can anticipate that there would also be hesitancy to immunize children in those communities. So we absolutely would benefit, I think, from having the community ambassadors be able to continue to answer questions and explain the reasons why COVID-19 immunization could benefit families, including the younger members of their families, as well as anticipated recommendations that would come down from the national level about who should or who could benefit from COVID-19 booster doses. So short answer is yes.
And on the topic, Eileen, or Dr. Davila, pivoting over to you on the subject of third doses. I know we are awaiting, and you went through it in the presentation, guidance from NACHI, ultimately direction from our province and supply. Is our team at Toronto Public Health now working on potential plans for if and when guidance recommends third doses for various populations?
Yes, briefly, Councillor, yes.
Okay. Those are my questions. Let me just see a last caucus round. Any other members of the board with questions? Okay, let's then move it in for for those who wish to speak, I'm going to put myself on to speak first. Let me just see by way of a show of hands, others who wish to put themselves on the list speaking on this item. See Director Mulligan. Are there any others who wish to speak on this item? Trustee LaPretti, do I have you? I believe I have you down on this. I do. Thank you. And I'll come back. So I have Director Mulligan, Trustee LaPretti. Anybody else who wishes to be put on this list here? Okay. Let me begin, and I can begin by placing a package amendment here with thanks to members of the board, and I'll single out Trustee LaPretti in particular for support on this. I will briefly summarize a number of the pieces. There are a series of amendments related to planning in our schools and 5 to 11-year-olds. Specifically, a request of the province to mandate vaccines for all publicly funded school staff, volunteers, and visitors in schools. A request of the province to ensure that as part of our 5 to 11-year-old planning, where there's a multi-pronged clinic model being built, that pediatricians and family doctors are part of those efforts. A reiteration of our request for additional dollars to support physical distancing within cohorts in schools, as well a request for our team at TPH to ensure the at-home PCR tests are at all schools and to accelerate work with the province as the continued work to explore antigen testing in schools is done. And then additional amendments not related to schools, I would just highlight on the subject of vaccine engagement teams, a request for our MOH working with the province and the city manager to acquire and ensure the adequate funding to continue that work for the next phase of the vaccination campaign and to report back to our December meeting on that status and any future plans, as well as a report back to our December meeting on the status and the latest guidance and status and approvals and plans for third doses. Members of the board, so that is the series of amendments. I will be brief because we still have 2 more items to deal with. But first, let me echo what others have said in a tremendous thanks for day 640 whatever of continuous operations by a remarkable Toronto Public Health team. I would argue that today's presentation was the most optimistic we've had in 19 straight months, and that is a data-led approach, and it speaks to a Herculean response by so many, including, I should note, our Toronto Public Health staff and the community. We heard this remarkable presentation on the work of the grassroots vaccine mobilization campaign led by and done in partnership with Torontonians, community agencies, community leaders, everyday Torontonians who stepped up. I would tell you that in my perspective, the vaccination campaign in this city, in a city of nearly 3 million people with 200 different ethnic groups living here, 140 languages spoken, a highly transient population. It is remarkable in a city as diverse and wonderful as ours that we are approaching 90% first doses and on the road to 90% for fully vaccinated, for eligible Torontonians. And I use this line that millions have been done and there's only thousands to go. And it's true. 2.3 million Torontonians are now fully vaccinated. To reach 90%, there's 196,000 to go and only 80,000 first doses to go. So let's keep going. But the model, what's most inspiring here is the model that's being built. It is a Team Toronto approach. It's not a slogan, right? It's hospitals, it's nurses, it's public health, and it's paramedics, it's community agencies and ambassadors, it's Torontonians. Everybody stepped up. We all collectively own this campaign because we are all collectively each other's, our brothers and sisters keepers. That's the power of this exercise. But we have more work to do. We have 5 to 11-year-olds. It's coming. And as Dr. Davila said, we anticipate and hope that not only will all 5 to 11-year-olds immediately, when approved, be able to access vaccines, plans are underway to ensure that an equity-driven model guides our outreach to ensure that those who've been hit the hardest are protected immediately. We have a third dose campaign to prepare for. We'll talk more about that in December. And we have systems in the future to improve and build upon and lessons we've learned from this. So this has been perhaps the most positive of meetings we've had in 19 months, but let's carry it forward. because the job is not done. With that, I'll conclude my remarks and turn it over to Director Mulligan first.
Thank you, Mr. Chair. I will be very brief. I want to extend my great thanks and appreciation to all of those folks working with the City of Toronto and the associated teams on the community efforts that have been undertaken over the past 19 months. Early on in the pandemic, I was always going on about 4 R's that I thought were really important, which was to release the data we needed to make good decisions, to help communities to reduce their contacts when needed, to represent diverse community voices in decision-making about what happens in community, and to resource community agencies and community people to do this work. And you've really pulled it off, and you've done that. And it's remarkable. It sets an example for not only this province, but the country, and I think the world, as to what an integrated and whole of government health equity approach can look like when community is afforded the opportunity to use the strengths that it has. And so I want to thank you for this. I'm very pleased to see how it is turning out. And I want to reiterate my support for our need to continue funding this work appropriately, because I think this is setting the direction for what public health and community well-being needs to look like, not just during COVID, but for all kinds of health and well-being issues related to health equity, social determination of health, and our sense of belonging in this city. So I want to congratulate you on this. I look forward to seeing the future evaluation results. And I hope that as a board, we can continue to lift up this work and find ways to apply the lessons learned from this as we go forward and consider some of those health issues that have been pushed off to the side of the table during the crisis. Thanks again.
Thank you, Director Mulligan. Next to speak, I have Trustee Lopresti.
Thank you so much. And I just want to say thank you to Councillor Cressy for helping put this motion together. The ones on education, I'd like to speak on a couple of them. The first one, to ask the province of Ontario to mandate COVID-19 vaccinations for all publicly funded school staff, volunteers, bus drivers, and visitors. We've noticed a very significant divide within the school boards, within the province. So there's different numbers. There are just too many inconsistencies in the vaccinations rates amongst different school boards. And I know that various boards across the province have been requesting similar to have the province mandate the vaccination rates for staff. So thank you, and I hope that you support this. With regards to the second point, I've worked a lot with Black Creek Community Health Center and Humber River Hospital throughout the summer with the vaccination clinics. As soon as the 12 plus age group was able to get vaccinated, and I'm speaking to hundreds if not thousands of people that went out to our vaccination clinics in our schools. There's certain questions. There's definitely hesitancy, and one thing that I would like to see is pediatricians be able to have the availability to vaccinate our students, our kids, because there is a relationship that's already built between doctor and families, and there's a trust element there. So hoping that will enhance the comfort level of parents in vaccinating their children. Another one, I'd like to thank colleagues at the Toronto Catholic District School Board with regards to allowing parents and guardian access into our school buildings. School boards are committed to creating school communities that are focused on the success, mental health, and well-being of all students, including safe environments for all during COVID-19. And parent involvement and engagement in a child's school contributes to the student's success. And they're great resources to school communities to enhance the educational experience for students. It's been almost 2 years that parents and guardians have been able to enter our school buildings. So I'm hoping that Toronto Public Health can work with school boards to allow to formulate guidelines in order to allow our parents and guardians access into the school with, proper PPE, full vaccination, negative test results, whatever it may be. But we've been very adamant on following public health guidelines throughout the entire pandemic and hoping that, our school boards can work in conjunction with Toronto Public Health again to allow already enacted.
Thank you, Trustee LaFreddy. Let me just open it up to see if there are any other members of the board wishing to speak on this item. Councillor Fillion.
Yes, I won't be making any motions today. And like everyone else, I'm glad to see the optimism and the optimism based on trends and facts. I'm much less sanguine about the Premier's optimism and, very concerned that in less than 3 months, potentially, and I know there are caveats, but potentially we could be looking at removing the requirement for vaccination and masking in a lot of indoor closed spaces where we know COVID can easily spread. So I can't imagine that his optimism is based on any data, but I don't know that my concerns are either. So I guess offline, I'll be continuing to ask if we can develop that data, which would give us a better indication of whether, under what conditions that kind of a change might be safe and what data would indicate that it is not. Thanks.
Thank you, Councillor. Any other members of the board wish to speak on this item? Director Bowery.
Morning, everyone. Just want to echo the sentiment of thanks that have gone to the Toronto Public Health team and community members involved in this. I won't take time. I just wanted to reiterate what a couple of directors have mentioned already today, which is the importance of having primary care and community pediatricians really involved in how the childhood vaccine delivery process happens. I'm fortunate to work at an academic family health team, which has been involved in vaccine delivery pretty much for most of this year. But I think what Director LaFreddy was saying is, we have trust built with families. We have kids that we are used to seeing, that we are involved in vaccinating them for their childhood vaccines anywhere. There is a lot of fear, there is a lot of hesitation, there's a lot of discussion that has been generated about COVID vaccines with families. And I think that primary care pediatricians in the community are best suited to have these conversations to allay fears. And if we have the infrastructure in place, I think we will allow for a very effective vaccine strategy in this age group. But I'm very pleased with how well we're doing as a city and a province thus far. Thank you.
Thank you, Director Bowery, and for administering yourself many of those vaccines, as I know you've been doing. Any other members of the board wish to speak? Okay, seeing none, we have, so then I'll turn to our recording secretary, Julie. Is the only item to move the package of amendments that have been placed? So
yes, that's correct.
Thank you. Okay, so we have the amendments as discussed on the screen. All those in favor? Thank you. Any opposed? Seeing none, that carries unanimously. Julie, you don't need a motion as amended, do you?
I don't, Mr. Chair.
Okay. So thank you. That concludes this item. And that was a comprehensive one. So thank you all. We will now turn to item HL 31.2, Black Scientist Task Force on Vaccine Equity. I'm delighted that we have here with us again Dr. Akwatu Kente, Special Advisor to the City of Toronto and Chair of the Black Scientist Task Force on Vaccine Equity, along with Anania Grant, who at this point is an honorary staff member of Toronto Public Health, though officially works for Social Development and Finance Administration. And so I will turn it over to Dr. Kente and Adenia. I know you have a presentation for us. We have no speakers on this item, so it is your presentation, and then we'll move it into committee. Adenia and Dr. Kente, over to you.
Thank you so much. So I have about 8 slides, and I want to speak very quickly so that we can move to discussion. It's been a long morning. Just wanted to say that the challenge of COVID-19 and vaccine hesitancy may be lessening in size and scope, but they are becoming more complicated and complex as we move to focus on child vaccination. Many vaccinated Black Torontonians are not convinced of the necessity to vaccinate their children, and even though their children have borne a disproportionate burden from school shutdowns, and this actually speaks to the need for messaging that is very sensitive and very well thought out. Next. To give you some idea of the ongoing community consultations the task force has been undertaking, I just wanted to sort of indicate we've been having town halls with churches. Last week we had a town hall with Destiny Dominion. Last Sunday, Evangel Temple. The week before that, First Baptist Church. This coming week, Black Legal Action Center, Black Youth Town Hall, and Newcomers Mental Health with Regent Park Community Health Center. So these are requests that have been coming in to the Black Scientist Task Force. We haven't been going out to create new opportunities for town halls, but what we are finding is a lot of people who weren't asking questions before are asking questions now. And the only striking thing I would say is that the questions remain the same, but the experiences that are being shared are visceral and speaks to a lot of racial or racializing experiences that we hadn't expected. Next. Again, just reiterating a critical point, huge vaccination rates will not change the fact that low-paid and racialized workers, especially those earning less than $25,000, still have to choose between financial well-being and health. What's particularly relevant today is that such parents are now being faced with a totally untenable choice between sending a potentially ill child to school and childcare because they cannot take time off work, missing prospective vaccination opportunities in the next few months is something that's uppermost on our mind. We also note in terms of speaking to the changes in the SERB that many workers have had hours cut during the pandemic and may not even be able to qualify for employment insurance, a factor, and there's several other key factors that matter, including losing a week. You have to wait a week for the new regulations. Next. They're moving quite. I want to remind you that in September 2020, just a year ago, Black Canadian hesitation was found to be 77% by the Canadian Community Mental Health Survey conducted in September. This October, the Ontario Science Advisory Table, doing its own survey amongst Ontarians, has found Black Ontarians expressing 36% vaccine hesitancy vis-a-vis their white peers. That's quite a change, quite an advance, but still a long way to go. I would not be surprised to learn that changes in Black Torontonians' perspective help to significantly reduce that rate. Next. However, mental health concerns sort of throw a wrench in the good news story. Black Torontonians are facing tremendous bereavement issues during the past 640 days. They've had double the losses in death, less time to grieve because of work constraints. One estimate indicates that for each death, left behind are 9 grieving relatives. On top of which, we've all had vicarious trauma from George Floyd, the George Floyd incident, which is not to be forgotten. No wonder then that a team from the University of Ottawa in May this year recently reported that 2/3 of Black Canadians are reporting severe depression, 6 times the severity rate for white Canadians. More than cause for concern, cause for worry. Our community partners are warning us about surging patterns, difficulty concentrating, children, youth, and parents, difficulty sleeping, more behavior problems, more suicide ideation than ever before, greater substance use, more expressions of hopelessness and helplessness, on top of which is increasing gun violence, referenced sometimes as being 15% more this year than previous years. And it's not a Toronto phenomena, it's a North America phenomena attributed to the job losses and the economic setbacks that Black communities have faced across North America. Next. We are therefore urging the City of Toronto to expand its wraparound supports in light of the severe social malnutrition. I just want to put quotation marks around that term, social malnutrition, being experienced by Black children, Black parents and families, especially our lowest income sector. That the isolation from friends and from essential play is having huge impacts and needs to be addressed. We are anticipating a significant surge in PTSD unless interventions, not necessarily traditional individual type interventions, but interventions of a social sort can be developed to reduce the potential spread. Next, or the worrying trend. Next. If you wonder about how the U.S. Public Health Service and the Center for Disease Control, which led the famous, perhaps infamous Tuskegee study for 40 years, denying penicillin to Black American men, one can only look at the world around us and the situation around us today. I often tell people who are vaccine hesitant because of historical mistrust that we have less to worry locally and nationally than is the case for people in the what used to be called the third world, the lowest income countries of the world. New terms are emerging. Vaccine apartheid is one, because promises have been made by wealthy countries as well as pharmaceutical companies. And as we approach the end of 2021, very few of them have been met. And it's a solid situation. And I can only ask that you communicate our distress at the obvious lack of urgency and empathy being demonstrated by our national and global actions with respect to the lowest income nations of the world. Next. As we contemplate how to address and respond to potential surges in mental health problems, particularly with respect to depression, anxiety, PTSD, panic disorders, suicide ideation, and suicide attempts, we need race-based data in mental health in order to plan effectively and avert what could be a catastrophe for Toronto in general, for Black and racialized Torontonians in particular. And so urge you to prioritize the collection of race-based data in mental health along with COVID and vaccines in order that our authorities can plan wisely in the short-term future, short to medium-term future. Thank you very much. And let me say quickly, it's been a privilege to share this journey with Toronto Public Health, SDF&A. Addressing a pandemic during the pandemic from a public health point of view is a privilege. Thank you very much.
Thank you, Dr. Kente. At this point, we will open it up to members of the committee for questions. We first caucus the committee to see who has questions. Councillor Fillion, is that a hand going up or is that a moving the camera?
Moving the cameras, sorry.
That's all right. Let me put myself on the list to begin, and then we'll come back. Dr. Kente, in one of your updates, you talked about the reiteration of the request for the City of Toronto to maintain its wraparound mental health supports for an extended post-pandemic recovery phase. Can you talk to the wraparound model of supports that have been developed from the perspective of the task force? What has worked? Like in its operations, what has worked? And as we look to a post-pandemic world where we're trying to improve health outcomes and learn from this, what is the model? What are the lessons learned that we should be taking forward?
The wellness checks have worked. The telehealth services that have been provided have worked, and in fact, could work better if there was more cultural adaptation of the therapies that's involved and the support that's provided. But it's been a lifeline for many, and we would hate to see it go, especially because PTSD as a phenomena doesn't occur during the crisis; it occurs after the crisis. And so we want to avert a potentially unmanageable scale of crisis.
Now, can you tell me, I mean, in the presentation we had on the vaccine engagement teams before this, I mean, in many ways, I mean, community-based models of care and outreach is, this is creating a pathway forward for how we improve health outcomes in a new city, or in the post-pandemic city. I guess where I'm curious, here we're the City of Toronto, not generally the provider of mental health services, but in breaking down the silos of social, community services, and health services, we're starting to provide better care. What have you seen in that alignment between how the city delivers services, how the province does, and how community agencies do in breaking down the silos to deliver better care? I'm curious what you, Dr. Kente, and Dr. and Anania, what you've both seen as we look to the future here.
I don't know. I don't have data, but I would think that what I feel is that the city's efforts has reduced stigma. I don't know to what extent the stigma reduction is, but usually the Black community, as well as other racialized community, have difficulty help seeking because of various internal stigmas about what it says about your strength or your masculinity if you express mental illness. But in having people come to you to do a wellness check, it actually has sort of gone over, which is a barrier that was actually found early in 2020 by a Stats Canada survey, which found that 2/3 of Black Canadians who said they didn't have a mental health problem, counsel if a Black one was provided to them. And here we have a situation where communication is being made from well-trained staff, sensitive to the nuances, and it's working. It's worked to some extent. I just don't know from a data point of view how well it's worked.
Can I ask on the data, the collection of disaggregated data, something that's referenced a number of times in the report? I mean, obviously there is the reiteration in the piece around the need for disaggregated data to be collected, on the vaccination campaign and mandated by the province. But it also you also speak here to collecting disaggregated data within the City of Toronto to inform not just the vaccination campaign, but issues related to mental health and ensuring a culturally competent response. Anania, I mean, I'm curious, the city recently announced its disaggregated data collection strategy. In looking to the future, how does that come into play here beyond the COVID disaggregated data collection?
Well, one of the things that we've learned through this process is the importance of a targeted approach. And we can't target the approach if we don't know. And so what I'm hoping and will continue to work with all our divisions on is ensuring that we use what has happened in this work, in this COVID work, to inform our race-based data strategy as we move forward. So we at SDFA, we're working closely with our equity office on this particular piece. Even around funding within SDFA itself, we've already started to pilot our efforts around collecting race-based data. So I would say that the lessons we're learning from this piece of work in COVID is going to be informing us, the city as a whole, as we move forward. And we will have a more comprehensive evaluation report for you. We've engaged a partner to do this. So we'll have a more comprehensive report for you in the spring, and we'll have a preliminary one in December. And that will show some of what you're speaking to, Dr. Kente, around how having race-based data has impacted how we respond to targeted population.
Thank you both. Let me see if the members of the board, are there others with questions for Dr. Kente or Anania? Right. Trustee Donaldson, yes.
Thanks, through you, Chair. Just to follow your last question about data, and I'm just looking at the slide deck on slide 8, availability of race-based data. And the call is to call upon the provincial government to institute this collection as well as the federal government in the census. And so my question is, to what extent is Toronto's approach reliant on or informed by the data from other jurisdictions?
Can I respond? Mr. Chair? Yeah. Through the chair, I mean, people have heard through the chair that it would be much easier if the province moved to collect race-based data through OHIP. It's come up on many occasions, and the opportunities have been repeatedly lost. That would make it a no-brainer for anyone else, any other municipality in the province, or any other jurisdiction within the province of Ontario. But without that, what do we do? The mental health consequences of the pandemic may itself be an epidemic. And the question is, do we wait for it to escalate, or do we try to intervene to prevent it from escalating? I would urge the latter, given the potential human costs, health costs that could be the result.
Thank you, Trustee. I'll do last call. Any other question? Okay, seeing none, we'll move this. Thank you, Dr. Kente and Anania. Move this into committee. Are there speakers on this item? Director Mulligan, please.
Just again, I want to, on behalf of all the board chair, my thanks to you, Dr. Kente, and to Ms. Grant, and to your teams for the work that you've done on this, and showing the importance of a targeted approach and what can be done when we tap into the strengths of community and of expertise from community members. So again, thank you for this, and I look forward to continuing to apply the lessons that you've learned throughout this process.
Thank you, Director. Are there others who wish to speak on this item? Okay, I'm going to put myself down as the last speaker here then. Let me begin by placing an amendment which draws from the recommendations in the report, which is being pre-circulated. This is first for a request for our city manager in consultation with the medical officer of health, along with our provincial and federal counterparts, to look at how the COVID-19 mental health responses that have been articulated when there can be maintained going forward and improved, especially through an anti-Black racism capacity building lens. The second is for the Government of Canada to apply a global health lens to the vaccine response from both the vaccine production and access perspective, and to assist provinces and municipalities to ensure that we can support that. The third is for the city manager and medical officer of health to continue and support the collection of race-based data within the city itself, along with the reiteration of our call for the province to mandate and facilitate the collection of disaggregated sociodemographic data as a core requirement as part of the COVID immunization campaign. So those have now been placed in front of you, and thank you to the Black Scientist Task Force for bringing many of these recommendations forward. Let me begin by, as we've done before, thanking the members of the Black Scientist Task Force, in particular Dr. Kente, who at a moment's notice dove in headfirst and joined our city on this march at a time when the disparities were unrelenting and painful and unacceptable, and helped to turn the tide through just a relentless community-based model grounded in culturally responsive expertise. And so to Dr. Kente and the whole team, thank you, as well as to the team from SDFA and TPH for seeing the tremendous importance of this work. The work, it has been nothing short of life-saving and transformational in reducing stigma around accessing services to increasing confidence in accessing vaccines. It has been transformational in our city. We have not been perfect. And the Black Scientist Task Force has helped us understand how much far we have to go in order to address inequities. But this work has been nothing short of remarkable. If I just on a personal level, as the chair of the board, look to some of the lessons we take from this as we look to the future, data. You have to collect it to inform the approach. If you don't collect the data, then it's easy for decision makers to ignore what's happening on the ground. And when you collect the data, decision makers must either ignore it or act in the face of it. And so data collection, co-created and worked on with communities is critical. The targeted delivery of services. The model of this vaccine campaign, where we have this Team Toronto approach, has broken down long-standing silos and barriers to accessing health and social services. You bring a mobile vaccine clinic outside an apartment building, which has been preceded by 3 days of door knocking in the apartment building to help people access vaccines. There's no reason we can't turn that same model on its head to do diabetes screening or to ensure people have access to income supports. There is a model here for the integration of health and social services and how we deliver them in a targeted community-based model that we must not lose sight of. And I guess just for me, the final lesson here that we cannot reiterate loudly enough and demand more, to be loud in our demands for all to be better on the topic of global vaccine equity. Nobody is safe until everybody is safe. And right now, everyone is nowhere close to safe in our globe. In fact, we're having long conversations around boosters, while frontline healthcare workers, people of color around the world are still treating a pandemic without access to vaccines. It's unacceptable. It's deplorable. And we must do better collectively. And so with that, I want to again thank Dr. Kente and his team. You have shown us the way forward, not just in responding today, but in how we can do better on a permanent basis. And we are committed to carry on that journey with you. With that, let me do a final call. Are there any others to speak on this item? Okay, seeing none. We have the one set of amendments in front of us drawn from the recommendations in the report. I will ask for a vote. All those in favor? Opposed, if any, that carries. Can I just confirm with Julie from our recording secretary, is there anything else on this item other than the amendment that was moved that needs to be done?
No, Mr. Chair. The amendment is all.
All right. That takes us to our next and final item for today, which is COVID-19 recovery update. We're at 12:10, so with the concurrence of the board, I'd like to move a motion that we extend to complete rather than break in 20 minutes only to return. I'm looking around, I'm seeing general head nodding. So Julie, do you want to place that now so we don't interrupt the item midway through? So this is that the Board of Health extend its meeting past the scheduled 12:30 lunch recess to complete the agenda. This is the final item on the agenda. So that has been placed in front of us. All those in favor? Opposed, if any, that carries. So I'm now going to turn the floor over to Chris Murray. Can I just say to members of the board, many of you haven't had the privilege of working with Chris. He is our city manager. I refer to Chris as my boss, as frankly, he's everybody's boss somehow. Many of you haven't had the privilege of interacting directly with Chris, but you have felt his immense role in leadership throughout this pandemic in nearly every report we've had in front of us, because he has been front and center of our response. And so, Chris, we're privileged to have you here. Thank you for the patience, and I'm going to turn the floor over to you.
So with that introduction, I should just leave now. It doesn't get any better. So
Look, I greatly appreciate this opportunity. I realize you've had a long meeting so far, so I've got 10 slides that I want to go through. Really privileged to be here, be in front of you, and look forward to your comments and questions. So maybe if we can, Dylan, we can go to the next slide, please. So as the title says, COVID has changed us in our city, and this notion of returning to normal, I think we knew early on that that was never going to be the case. That as difficult as this challenge has been, we've learned things about ourselves and our community, and I think as the first two items on the agenda have pointed out, there's really no turning back in terms of the way in which we have to approach designing and operating the city. So yes, we do continue to build a strong foundation for recovery, and the evidence, as you point out, this is the presentation from Dr. Davila was positive, and that's all because of the incredible work of, and I must tell you, your political leadership on this matter has been extraordinary. This council has responded as you would hope. It's been led by a mayor that has done, I believe, a phenomenal job paying attention to the details. And of course, your board chair, Councillor Cressy, who we're all going to miss for his leadership, has been, and I don't just say this, has been phenomenal. And I've worked with a lot of politicians over the years, and the commitment to this great city by all those decision makers has been nothing short of fantastic. We're not done yet, as pointed out. We have not run this to ground. We still have more work to do. But what became really evident to, I think, all of us as we witnessed the populations, the equity deserving groups that were impacted and are still being impacted by COVID, the matter has gotten bigger and bigger and bigger, meaning that we need to really turn our minds to how it is that we help all people in this community. And I don't need to tell anyone on the Board of Health what the social determinants of health mean and how critically important they are if we're going to be as great a city as we can be coming out of the COVID matter. We said day one, all of us, that we're going to save lives, we're going to save the healthcare system so it didn't get overrun, that we would find ourselves out of capacity from an ICU standpoint and so on. But also we're going to save livelihoods. So protecting public health as is and will remain our priority. And of course, during all that time, people may not realize this, but about 75% of our organization kept doing the job it's always done in terms of picking up waste and making sure water is safe to drink and so on. So it was business as usual for some, but for some of us, we had to stop what we were doing and really focus on the pandemic at hand. And of course, prosperity, and I'm going to talk more about this in a minute, remains and has to remain critical to all of us. Next slide, please. I think this is a bit of an understatement. Inequities remain a concern. They were significant before the pandemic. They've only been exacerbated as a result of the pandemic. And the notion that beyond the pandemic that we don't fundamentally address these would be such a colossal mistake. And I'll explain that a bit more in a few minutes. But what this slide really does is to show you the various populations of our diverse community and how they've been affected by COVID. So when you look at the Arab, Middle Eastern, and West Indian, they make up 4% of the population, but yet from a COVID impact standpoint, they were 7%. Our Black community represents 9% of the population, but yet 14% experienced COVID. Our East Asian wasn't as significant, but still 7% were impacted. Our Latin American, our South Asian and Indo-Caribbean, and our Southeast Asian, all of which with lower populations experienced more of a COVID impact. And then the white population, which represents 48% of the population of Toronto, 27% were impacted by COVID. What are the fundamentals? And I'm not going to repeat Dr. Lamptey and Ms. Grant's presentation. I think they said it about as well as anyone could. The fact of the matter is we know, and this is the fundamental focus that we need to have, I think, moving forward, is to address the systemic racism that exists, to address the discrimination that exists, to address the barriers that populations, as the ones I just mentioned, experience to participate in society in a manner that they need to and must if we're going to be successful as a community. Next slide. So as you would hope, over a year ago, really in the first quarter of 2020, it became evident that we needed to make sure that we stayed on top of the COVID problem as it was evolving. And as I think Dr. Davila points out, I mean, we were learning constantly. And I think the chairman will know if there's one word that we use a lot, it was the word pivot, and we pivoted, and as often as we could and had to, as well as, you know, we did work at a very deliberate speed. And I can say this, I think, in terms of our response. I mean, a very large organization like the City of Toronto, I think if one of the great takeaways from this is that we proved to ourselves an organization that's made up of about 44 program areas came together very quickly, responded very quickly. And as a city manager, I'm fiercely proud of the phenomenal work of everyone. And of course, the phenomenal leadership of Dr. Davila and her team and many others who I could name, but we don't have enough time. But I want to point out, though, in creating the office, you know, I wanted to make sure that some of the advice that we're going to be getting was not just from ourselves, but from a couple of people who would be instrumental, I think, in leading such an office. So Dr. David Mowat, I think people probably know who he is, but he was the medical officer of health for Ontario, Associate Medical Officer of Health for the country, as well as Medical Officer of Health for Peel. And so a long established, incredible career. So it was critical to all of us that if we're going to get some outside support to look at maybe more of the medium, longer term measures that we should be thinking about, that we would ask him to give us some assistance. And with him was Mr. Saad Rafi. And for those that are familiar with provincial administrations, Saad was a deputy minister for over a decade, serving in the health file, the environment file, and other files such as infrastructure. And so has a very good understanding of the federal, provincial, legislative, policy, and regulatory frameworks that exist and how they work, and in some cases don't work. So it was important to me that I had those two gentlemen to assist a very large team that came together in the form of the office to come up with not just immediate measures to help in addressing recovery, but the word rebuild, to look at the way that we should be positioned going outwards. In other words, the next 3 to 5, 10 years and beyond. So that's why those two individuals were part of the team. And of course, the report was published in September of last year. It contains 83 recommendations, and they cover themes of, as you would hope, public health, of course, social determinants of health, prosperity, infrastructure and mobility, resilience, and then the City of Toronto services. So, and I'll cover this in a few more moments, but Recovery TO, if you want to go to our website and type that in, you will see exactly all of these recommendations. And if we can go to the next slide, please. Speaking a little bit more about this, that since last year, there's been 10 reports that have been published on our recovery efforts and rebuild. And of that report that I just mentioned, with the 83 recommendations, 32 have been implemented, 42 are in progress, and some of those are ongoing. Meanings, for example, if we talk about working with the federal and provincial government, that's an ongoing, that's a relationship matter, as well as working with the other municipalities within our region. And of course, 9 with divisions that are under review. So this is a work certainly still in progress. And again, the city priorities are both in terms of the immediate response, but also the long-term recovery and rebuild, really. And something I'll just pause a little bit right now. When we think about the federal and provincial government in a major city like Toronto in the Canadian context, many of us have long talked about an urban agenda. And then we've never really seen such an agenda come from a federal government, for that matter, a provincial government. And in some respects, the way that we approached this document was to start to frame, if you will, what would be some of the important items that a municipality like a Toronto, or for that matter, a Montreal, a Vancouver, and so on, things that are going to be germane to us, but obviously affect because they control in many cases the other services that are critical to being a successful city. So in some respects, I would suggest if ever we are going to get an urban agenda in this country with all levels of government working together, some of the details that are in our document, I think, would be probably quite helpful. And of course, all of this, I mean, at the end of the day, talk is talk, plans are plans, but until you actually start investing in these measures that are being recommended, not much does happen. So this has become part of our budget process, and so work that we're doing is regularly communicated to council, as I mentioned before. Next slide, please. So it struck a number of us, and I think all of you on the board, and of course the chair. If we think about what is prosperity, I mean, I think whether it's cynical or not, I suspect it's a reality that has plagued many people in this community, that if all that we're about is the rich getting richer, then where is that going to get us? And at the end of the day, what I think a number of us thought is that if we're going to talk about prosperity, the question becomes who's going to prosper, and how are they going to prosper, and what are we going to actually do about that to make sure that all people that call Toronto home are successful. And so when we looked at it, we felt that there are at least three major considerations that one should use when defining what prosperity in Toronto means. And so we think about that. We think about it in terms of equity and reconciliation. Those two concepts should underpin any definition of prosperity. The notion of resilience or climate action, and those two are obviously connected. We cannot, for this generation and many generations to come, not make the critical investments that we have to, and to implore the federal and provincial government to do more than is maybe what was contemplated before in terms of getting to where we need to be from a carbon perspective, and all that is underpinned by resiliency and climate action. And as I think we just heard in the last presentation, when we think about our prosperity, how do you achieve it without a very deliberate and very clear focus on health and well-being? And so that motion that I think the board just approved unanimously about the medical officer of health working with me, that is absolutely the right move going forward. We have learned a lot. I think a lot of what we're talking about, to me, is consistent with good community development. We've learned through the COVID program what that can do and how that can unfold and the results that would come from it. So maybe in a much bigger sense than our continuing efforts together, whether Dr. DeVille and myself and the Toronto Public Service, I think it is so critical that we work together in an evidence-based decision-making format. And I'm going to talk a bit more about that in a second. Next slide, please. It's interesting. I mean, history repeats itself. And if you're not careful, sometimes it's good, sometimes not so good. I have a staff member who originally was hired back in the early 90s to work in the Healthy Cities office within the city manager's office in 1990. And that existed for about 10 years. And then after that, after amalgamation, there was other, what is now, I think, painfully obvious good advice. When we think about, what does it take to run a community successfully and to have a quality of life that all people want to celebrate and enjoy, well, health is so fundamental to that if we're going to have that kind of success that we all want. And then the second point, and I think you've said it in the first two presentations, but I'll just underscore it. The whole of government, whole of community approach is our only way forward. The idea of levels of government operating in siloized manner, and for that matter, the City of Toronto acting in a siloized manner, we are never going to be able to tackle the systemic challenges that are facing us right now. And we really have no choice but to learn how to communicate with each other, to set outcomes that we need to collectively achieve, And that's not just government, that is the whole of community as well. So if we want to tackle prosperity in the manner in which I'm talking, this is the only way of doing it, I believe. And with that, let me go to the next slide. So what does this notion of investing in prosperity as defined previously mean? It is investing in the social determinants of health. And yes, not all of them are fully within our control. Some of them are well beyond our control. So when we think about education and employment and income, these are matters that, we don't pass bylaws on or have direct oversight. And so to ignore them would be at our peril, but they are part of what we know to be critically important in social determinants of health. Other matters, and I'll just say this, when we talk about equity, there is, with the economy of evolving in the manner in which it is, and most things becoming digital, you have to, when you think about equity, you have to think about digital equity. And how is it that people are going to be able to be educated or participate in an economy if they're unable to afford, broadband, if they have inadequate access? When you hear about people having to go to Tim Hortons to take advantage of the broadband that's available there because they don't have it in their home, and I know we keep thinking about digital infrastructure as a rural issue. We know that within the city of Toronto, there are areas that are lacking the kind of capacity that are necessary. So, again, social determinants of health, critical to our success, whole of government, whole of communities approach, which I mentioned. And of course, in everything that we're doing, and it's increasingly becoming an important way of evaluating our budget, is by applying an equity lens and emphasizing human dignity, which is a basic underpinning to the right to housing, which we're going to talk about in a second, to support how we make decisions, how we invest our resources. The next point here, regional coordination and cooperation. I mean, my background is urban planning. I've enjoyed city building for a long time. And when I think about Toronto, it's almost impossible to think about it without looking at the city state that we exist within. I mean, this large urban mass that we're part of. What we do in Toronto, if it's not supported with equal measure in the other municipalities that make up the GTHA, for example, it can be undermined. And so I think as we try to connect public health and the social determinants of health here in Toronto with the decisions we're making, we got to work with our colleagues around the GTHA, which we do right now. I'm proud to say that we have tables that are focused on transportation and housing and digital infrastructure and other measures. But, it's really important that, the way we work, not just with the federal and provincial government, also with our friends and neighbors within the GTHA. And I would just simply say this as well. When you look at the gross domestic product of the country, when you know that over 25% of it is occurring within about 50 minutes of school, it makes sense, I think, to many of us that as we approach this challenge that we do so in partnership with the municipalities that are around us, making up this incredibly large, successful economic region. And then, of course, we can't continue to make the same mistakes as we have in the past. We got to be a little bit braver, a little bit bolder, not afraid to suggest to upper levels of government as to how this thing ought to, this challenge that we have in front of us, how we ought to approach it. And then monitoring and measuring. I mean, I can't say enough about the role of public health, not just in helping us, design, operate, implement cities, but to make sure that, when we look at things like rapid housing, when we look at, our shelter system, I mean, the effort that, needs to come from public health to make sure that, that we understand what we're accomplishing, what we could do better, I think is a critically important role that this group can play. Next slide. So before I go to my last slide, which is right after this, I just thought it was useful. The last time we had a major pandemic, not a great surprise, housing was a challenge back then. You can see in the background Old City Hall, but you can see the state of housing for the population that lived in Toronto at that time. And to your right is some modular housing that that has been built here in Toronto. There is obviously a focus on affordable rental and home ownership, but also, and I think we're talking about it here, the role of supportive housing in this city. I mean, of the 40,000 units that we're projecting to get built in the next 10 years, about 18,000 is related to supportive housing. And we do have a relationship with the University Health Network. And Councillor Perks, who is very familiar with some of the work that we're doing with them in United Way and others on social housing. I mean, at the end of the day, when you hear from Kevin Smith that 10% of the population that access to hospital services consume 80% of the resources, one has to ask, who are the 10% we're talking about? And many of them are the ones that are struggling in deep levels of poverty. Many of them are homeless. So when we talk about supportive housing, it's not just a housing first approach. It's not just about putting a roof over someone's head. It is making sure that the mental health and addiction services that we don't control as a city, but are certainly there and being provided for through funding or direct service from the province and or federal government, that this is why we need to work together. And so when a person has a door they can lock and they can come to the point where they want to have help, that help not only has to be available in quantity and quality, it has to be very accessible. It can't be just at someone's office. It has to be, and this is a model that I think we need to evolve, where we are thinking more in terms of the evolution of social medicine in this community. So working with UHN, working with CAMH, working with the many different institutions that we do work with has to be a priority, because if we don't address it, we are going to not only let down the people that deserve better. I look towards the future with an aging population, just how taxed our services are going to be, and I would like us to find ourselves in a place where a hospital is able to deliver its services in a manner where other services that were dealt differently, such as through social medicine in the community, we're there and we're able to help people in the manner in which they need to be helped. So apologize for the length of my presentation. Dr. Davila and I talk, as you would hope. I look at Dr. Davila and what she can do in terms of, giving great guidance to this organization and helping to shape its policy and its direction. I see her as a strong partner. And I'll end with this. I just remember years ago when the big move came out and all the MOHs got together to write a commentary on that regional transit approach. As an urban planner, I applaud it. The fact that public health was weighing in on infrastructure investments and weighing in on other policy, I think is really our way forward. So I will end there and look forward to any questions or comments you have to make.
Well, thank you very much, Chris. Let me open it up for questions from the board. I'll put myself on. Chris, you articulated, you provided the roadmap. You talked and how we're tracking it, the 32 implemented actions, the 42 in progress, 9 for review and so forth. So is there a dedicated office or a dedicated team within the city, within your office, that is tasked with overseeing the TOR recommendations and tracking them? How is this being tracked and how are we held accountable for it?
Thank you for the question, Chairman. And the short answer is yes, it is being overseen by the city manager's office. Meg Shields is and Kate Bassel are the two fortunate, maybe unfortunate people that I turn to every day to make sure that we keep driving this. Otherwise, it becomes just words on a paper, and that's of no value to anyone. So, but they are, as you would expect, dialed into the 44 program areas in the organization, and so they are connected with them and making sure that what we had committed to in the recovery rebuild document is happening.
And so then, if it's okay, Dr. Bill, I'll pose question over on our TPH side is, we are, and your team is and has been all consumed with responding to this crisis, but your team also contributed greatly into the development of many of these recommendations. At what point, and has there been any conversations around at what point we will be in a position within TPH to have dedicated leads focused on looking to the future and the recovery and response items in the report? When do we move from the response phase to having the dedicated resources in our own TPH unit to support, to support the overall tracking and implementation of some of the public health specific recommendations?
So through you, Mr. Chair, I wish I could give you a very specific date. And as you know, we still have a significant amount of pandemic response in front of us. So what I can say is we're eager to get on with this work. As you can appreciate, this is really about the broader, all the aspects of public health that we're, frankly missing and would really love to do. That being said, I think through the presentations you've heard today, there have been a number of instances where the specific collaborations that we have had with healthcare providers, with community agencies, with community providers and other stakeholders actually provides a little bit of a jumping off point for the work of the future. So we are absolutely working on COVID-19 response in this, very whole of community way. And while it is focused on COVID-19 right now, the hope is that we use this kind of interaction and the relationships that we're establishing through the COVID-19 response to then move on to other aspects of work that are going to see us better able to achieve our objectives of improving health status, reducing inequities, and ensuring that we're preparing for and able to respond effectively to outbreaks and emergencies on an ongoing basis.
Thank you for that, Dr. Davila. Let me open it up. Are there other members of the board with questions? And I would note off the top, Chris, we didn't put you last right before lunch as a deliberate way to avoid questions, as you know. Let me just see, any other members of the board? Director Mulligan.
Thank you so much, Chris, for this presentation, for this update, and the forward thinking about social determinants, equity, climate resilience, and so on. I just have a quick question about community involvement in the report and in the work of what happens as we implement the recommendations. What structures are in place to ensure that the most impacted communities have a voice at the table?
So, I mean, and I didn't mention it, but I look at the work of, that we're doing through Safe Communities, what we're doing in terms of our homelessness strategy, in terms of our whole housing strategy. I mean, there are multiple plans that are unfolding right now that all of which have a community, not just involvement, but, critical engagement aspect to them. So we can't deliver on these plans. It's the old saying, not about us without us. I think we're going to, and if we were even to try to do something without involving those most directly able to deliver those services or are most directly impacted, I think, people will be pretty quick to call it out and to slow and stop us. So, it's not in our interest to not work in a very engaged way, especially given the challenges that we just talked about. So, so we have multiple strategies that, whether it be through our housing secretariat, our work that we're doing on Safe Communities, as I say, all of these programs are all built with kind of a community development, community engagement mindset.
Thanks, Kate. Let me just final call. Anybody else with questions? Okay, we'll move this into committee to speak. Let me put myself just first on the list, and I'll begin by placing an amendment, which is to request our MOH in consultation with the city manager as part of 2022 to report back on the status of implementing the recommendations that pertain to public health and the social determinants and to continue consulting and to consult with communities disproportionately impacted. And that I say that is in an effort to ensure, as Chris Murray mentioned, that this continues to be more than a strategy that was developed and put on the shelf, but rather a living document to be implemented, refined, and improved. And I want to start by thanking the city manager, and he mentioned the whole of government team across divisions, across the city, including our partners at Toronto Public Health for their work to not only initially develop this roadmap, but to ensure that it guides our path forward. I, like so many at the beginning of this pandemic 19 months ago, many of us felt, just as we were terrified about what the pandemic would mean, that it also was an opportunity for transformation, to establish that new deal for cities, to set the course in responding to the pandemic, to address the issues the pandemic laid bare, from housing to access to services, and then in a way we all became absorbed in the real-time response. But I believe, as Dr. Davila mentioned, because our response, especially I believe from the City of Toronto, was equity focused, our response helped to not only identify and pinpoint the inequities, but to seek to create solutions, policy solutions, partnership models that could be part of the long-term permanent policy landscape of our city on a permanent basis. And so, just as this pandemic was a wake-up call, it has also, I think, led to some potential strategic and transformational systems. And in this TOR report, I apologize. I must apologize to our city manager, because we've tried to get it on this agenda in the past, but we pushed it because we're endlessly dealing with the urgent response. But this is the roadmap. This is the vision. This is how we seize this moment and plow through the fatigue and the emergency response to set the stage for the future we need and deserve. And so we are duty bound to plow through that fatigue, to live up to the recommendations and the vision articulated in this report, and to do our very best as we come out of this pandemic to seize this moment. And so I thank the city manager and his team. And as a board, we will, as we move beyond this pandemic, look to use this as our guiding post on a much more frequent monthly basis. And so thank you to all. Let me just see if there are any other speakers on this item. I recognize it's time and it's late. Director Mulligan.
Very, very briefly, and I mean this as a general comment and not as a critique of the fantastic presentation and the fantastic work that's happening. But I want to just remind us all that we need more than an equity lens when we're doing this work. We need equitable structures, and we need those structures to be inclusive of the voices of community, and to include ways for us to continue learning and improving on this work. So just an overall comment that it's not going to be a lens we can take on and off, or a way of looking at things from privileged positions, but a real structure that includes all of us in the recovery. Thanks.
Director, are there any other speakers on this item? Seeing none, thank you, Chris, for spending the morning with us. Julie, we have the motion that was moved to be placed, if it can be. There it is in front of us. And with that, I'll call for the formal vote. All those in favor? Opposed, if any, that carries. Directors, that concludes our meeting. Thank you all for the indulgence on the time. I would note, just in preparation, and we'll follow up individually, our December 6th meeting may be a full day meeting based on our early agenda forecast. So we'll follow up to caucus you all individually around that, but I would just make a note, and if it's possible, to plan to be here for a long session on December 6th. And thank you all for today. This meeting is adjourned.